Yeah, thank you. A very good evening to everyone. My name is Abhishek and I represent Dr. Reddy's today. In fact, we had a very good 5-day program by the name of Year in Review Hematology. Of course, a great help from Dr. M.B. Agarwal sir and the Mumbai Hematology Group. The entire program was designed with his help. And no, before I hand it over again to sir, I just would request you to bear with me for another 2 or 3 minutes. Just wanted to share a few things about our organization. Happy to share that our all India field force and entire Dr. Reddy's employees are 100% vaccinated, and hence I think it is goes very well with the ethos of the company. Most of the employees were vaccinated by the month of June and July. So no, it would be relatively safer to meet Dr. Reddy's employees. We also wanted to share with you, there are apart from a long list of products in pipeline, I thought of sharing there are three very good promising molecules which are into pipeline. One is, of course, the CAR-T, and a very good development in terms of timelines have happened, and we are happy to share that we have already started work for bringing a relatively affordable CAR-T to India and for Indian patients. And the first one to come will be the BCMA followed by CD19. Though it might take another 2.5, 3 years, but our GMP facility is ongoing, and we already have associated with our organization for BCMA, and we are in talks for the CD19 thing. One another molecule which will go in the clinical trial soon would be the first oral immunotherapy, which targets PD-L1 as well as VISTA. I think it should go in the clinical trials, and if it comes out well, I think it would be a great boon for the Indian patients again. We are also working on another molecule which is targeted towards FGFR and VEGFR, which should also go in clinical trial in another 1 year. So these were the three quite promising molecules that I thought it worth sharing with the group. I think everyone is aware that Dr. Reddy's is an organization which is committed to quality biosimilars and products. Some of the products that we have are Reditux, which is the first biosimilar of the world. CRAS 500 is the first biosimilar dabopoid in 500, long-acting 21 days. We also have the innovator carfilzomib in the form of Kyprolis, and the only bioequivalent dasatinib in the form of Invista, which was studied in 6 continents. And this is the entire hematology portfolio. And just before I end, I think I also wanted to share that as an organization, we have a separate team called Dr. Reddy's Research and Education, which also does a lot of training programs for allied healthcare workers and young students. And there are a lot of programs that we run for paramedics as well as other staffs in terms of training them in terms of their job profile as well as soft skills. This is run by DRFHE, and that is what I just wanted to share with you. With this, I think I would hand it over to Dr. M.B. Agarwal, sir. Thank you. Thank you for your time.
So thank you, Abhishek. Good evening to one and all. This 5 days webinar was a brainchild of Dr. Reddy's, executed by Mumbai Hematology Group, called Year in Review Hematology 2021, as the contents were essentially what was published or presented during the last 10 months of 2021. As Abhishek just mentioned, from Reddy's house, we have a very important molecule which is relevant to the discussion today. Today is Lymphoma Day as far as our webinar is concerned. And they have the molecule Reditux, which represents rituximab. All our webinars have been managed by Mice Ideas throughout last 1 year and 6 months. Over 150 webinars, flawless management, and I'm grateful to Mice Ideas for that. Today is day 5 of this webinar, Friday, 22nd October, and the theme is lymphoma. It's my privilege to introduce our chief guest for the day, and that is none other than Dr. Ashok Ved. Dr. Ashok Ved does not require any introduction, but I have to complete the formalities. All of you, those who have logged in, know him for decades. Dr. Ashok Ved is chairman, Medical and Hemato-Oncology, Cancer Institute at Medanta, the Medicity, Gurugram from 2009 till date. Earlier, he was head department of medical oncology at Artemis Institute from 2007 to 2009. Prior to that, senior consultant and coordinator of medical oncology at Rajiv Gandhi Cancer Institute from 1997 to 2007. And prior to that, medical oncologist, Government Medical College, Jammu, 1994 to 97. He is the founder member of the ICON. He is life member of the Breast Cancer Foundation of India. He is member of ESCO, ESMO, IHA, and many other national and international organizations. As stated earlier, he was awarded with Padma Shri in 2009, the 4th highest civilian award of the Republic of India. He was also awarded with Chikitsa Shiromani Award in 2007. He is on the editorial board of Current Trends in Asian Oncology and a consultant editor for JK Science. He has carved a niche for himself as a pioneering medic in the field of bone marrow transplantation, as the unique distinction of carrying out the first 25 bone marrow transplants in any private sector hospitals in North India. He has also conducted over 40 international national studies in clinical research. He is known for organizing numerous seminars, workshops, and conferences. He has authored many publications and research papers, and he, of course, has over 3 decades of practice. Dr. Ved, I'm privileged to invite you to inaugurate our today's webinar and give us some words of wisdom. Thank you. You are muted, Dr. Ved.
Good evening, everyone. Friends, those are very kind words and very generous words. And I must say that Dr. M.B. Agarwal has been really the pioneer who's actually been spreading the medical education. And it's said that the biggest noble cause on anywhere would be spread of education. I thank you, sir, you for pioneering this concept and then inviting me to be a part of the proceedings this evening. It's an honor and a privilege to be here with you on this virtual platform. My thanks to Mumbai Hematology Group and DRL for making me a part of the proceedings. Your programs, sir, are renowned for the completeness and the compactness, and also the diversity, the way you organize them in terms of lectures, panel discussions, debates, and the other ways of dissecting out a particular topic. I wish this meeting great success, which I'm sure under your dynamic leadership, it would achieve greater heights year on year. We are all looking forward to in-person meetings. Times are different, but friends, nevertheless, we do anticipate that all this would happen soon enough. The science of oncology is so ever-changing that we are getting updates and newer drugs, newer diagnostics, newer concepts almost on a weekly basis. So it's a very logical culmination of reviewing the data, reviewing the publications, updating our knowledge, and putting it into a year in review, which, sir, you have very diligently done. Thank you so much once again, and I wish this conference a great success and a great learning to everyone who's a participant here. Thank you. Back to you, sir.
Thank you, Dr. Ashok Ved, for those very kind words. I'm grateful to you for sparing your evening, joining us, blessing us by these wonderful words and inaugurating this webinar. I'm proud of my friendship with you. Thank you. We will now be moving to the first segment of today's webinar. Those of you who logged in late, I must tell you that this webinar, all 5 days, was the brainchild of Dr. Reddy's and executed by Mumbai Hematology Group and named Year in Review Hematology 2021 as the essence of this meeting was what has been presented and what has been published during last 9 to 10 months. From the Reddy's house, we have a very important molecule, Reditux, which is rituximab, which you and me have used in the treatment of lymphoma and allied conditions for more than 1.5 decades. We begin with the lecture of the day, and this lecture is entitled Sequencing Therapies in Follicular Lymphoma. And if you have anything to do with lymphoma management, you know how important is sequencing in the treatment of any disease. And again, I'm privileged to have my dear friend, Dr. Reena Nair, to give this lecture. You all know that she is now Senior Consultant Clinical Hematology, Head Department of Medical Oncology at the prestigious Tata Medical Center, Kolkata. Before she deserted us, she was for almost 2 decades in Mumbai at the similar position in Tata Hospital in Mumbai, very adjacent to the place where I worked for a decade, KEM Hospital. And she was a very, very active member of Mumbai Hematology Group. Although she might have moved to Kolkata, but she has blessed us by her kind participation in our scientific activity day in and day out. So over to Dr. Reena Nair for her talk.
Thank you very much. In today's world, there is no dissertation. We are all together on the webinar. And so it's a great platform to be on. Good evening, everybody. I will share my slides first. So I will speak today on sequencing of therapies in follicular lymphoma, as Dr. Agarwal has just mentioned. We know that follicular lymphoma is a common disease with clinically indolent behavior, and it has a very long natural history. If we look at the outcomes at 10 years, the overall survival in various patient data sets have been anywhere between 76 to 79%. And for a malignancy at the end of 10 years, this indeed is a great thing to be. But however, gradually we have begun to realize that slowly there are some patients who kind of lose the control over this disease and continue to die either because of transformation or multiple recurrent diseases. And this number continues to increase and becomes more than about 10% at 10 years. So we know that 10 to 20% of the patients will experience early disease progression, which we now describe as POD24. And these are the patients whose outcome and overall survival is far less as compared to the other follicular lymphomas. In these patients, the 5-year OS is about 37 to 50% as against what I showed you. For most other patients, it would be about 80 to 90% at 5 and 10 years. Additionally, there is a subset of patients who are refractory to both anti-CD20 antibodies and alkylators. These are called the double refractory patients, and they are patients who continuously relapse again and again and have a propensity to transform to aggressive histologies. So this 20% of patients is what we actually need to look for in the first diagnosis, because these are patients who do not enjoy the long natural history of follicular lymphomas and the median survival of overall survival of 2 decades. So again, just to show you pictorially, the overall survival of patients who are given the first line of therapy is quite excellent. But if they start relapsing, then each time the median survival goes on decreasing And ultimately, it is really short by the time they have reached the 4th and 5th line of therapy. There is a group of patients who are now called early PODs who relapse within 24 months of the diagnosis. And these patients have an overall survival which is less than half at 5 years as compared to the other patients. And again, there is a third group where transformation happens in less than 18 months from the diagnosis of follicular lymphomas. And these patients again do not do as well as the remaining patients of follicular lymphomas. So it becomes extremely important to have prognostic and predictive markers through clinical calculators, functional imaging, genetic mutations, and the research that goes on at the microenvironment level to be able to actually find these 20% of the patients who are not going to be doing as well as the remaining patients of follicular lymphoma. We all know that the FLIPI index has stood its test of time with 5 characteristics, which had a relative risk of death as described in this slide. And it helped us to group these patients into low, intermediate, and high risk with a 10-year overall survival ranging from 71% for the low risk patients to 36% for the high risk patient. Desperate attempts have been made to improve on this prognostic calculator. We have the FLIPI2, we have the FLEX and the PRIMA PI, which is all patient-based at diagnosis. Tumor-based diagnosis, we have indices like the histological grade, which has been there with us over time. And we all know that grade 1 and 2 do much better than grade 3, and especially as compared to 3B. More recently, functional imaging with PET is trying to evaluate if they can actually find these 20% patients who are at an increased risk to relapse and transformation, so that we can do something which is different upfront rather than for them actually to relapse or transform and then start doing something for these patients. So if we look at the indices that have been available in the pre-chemo rituximab era, when it was only chemotherapy, it was FLIPI. Then came in FLIPI2, but these have been inconsistent in the validation sets. The PRIMA PI actually looks only at beta-2 microglobulin and bone marrow involvement in the immunochemotherapy times. And with the coming of bendamustine and obinutuzumab in follicular lymphomas, the FLEX score has come. But the sensitivity and specificity of all these calculators is hardly 50 to 60%, which means they actually do not really find the patients who are at a high risk for doing poorly after a diagnosis of follicular lymphoma. And lastly, predicting for histological transformation means that patients who come with high risk FLIPIs have an elevated LDH and a grade 3A histology must be monitored for transformation, especially if they present with poor performance status, B symptoms, and they have been previously treated with chemotherapy, immunotherapy, or the time from their diagnosis is short. So coming now to the actual talk, which is sequencing. After having found which are the patients who really need treatment, it is patients with high tumor burden. And for a long time, we know that rituximab is a drug of choice, and the chemotherapy backbone can be CVP, CHOP, bendamustine, or fludarabine-based therapies. And today we will see how we sequence these. So beyond doubt, the addition of rituximab to conventional chemotherapy has improved the outcomes of follicular lymphomas on all parameters, whether it is overall response rate, complete response rate, progression-free survival, or overall survival. And this has been shown across 4 randomized clinical trials. So there is no doubt that we need to have immunotherapy in patients of follicular lymphoma. The question now is which anti-CD20 is to be used, and what is the chemotherapy backbone? That is something that remains unsettled as yet. We have the landmark gallium trial, which looked at obinutuzumab in randomized to rituximab in patients who were receiving chemotherapy. And the chemotherapy at that time was bendamustine in 60% of the patients, CHOP in 30% of the patients, and CVP in about 10% of the patients. These patients were given chemotherapy followed by maintenance therapy for about 2 years. And if we look at the hazard ratio, it was 0.66, which actually equates to a 34% risk reduction. And at 3 years, 80% of the patients who received obinutuzumab with chemotherapy were in remission as compared to 73% of the patients who received rituximab and chemotherapy. So there is a superiority as far as progression-free survival is concerned, but there was no difference in the overall survival. Besides, obinutuzumab happens to be slightly more toxic. It has more infusion reactions. The episodes of cytopenias are more, and there are more infectious complications as compared to rituximab. So it still remains doubtful whether obinutuzumab is indeed a superior anti-CD20 monoclonal antibody. However, it is there and available as part of the treatment for us. The next question is, which is the chemotherapy which is the best for combining with the immunotherapy that we already have? And the STILL trial actually looked at bendamustine versus CHOP in combination with rituximab. And no doubt that they have actually demonstrated that BR has better efficacy and has much reduced toxicity. So for some time now, BR has become the standard of care. If we look at the parameters, this complete response rate, the progression-free survival, especially in this particular trial, which included all indolent lymphomas, the PFS for patients of follicular lymphoma and the time to the next treatment were all significantly much better for the bendamustine rituximab patients as compared to the R-CHOP arm. Again, if we look at the toxicities in these patients, then there is no doubt whether it is neutropenia, leukocytopenia, the use of growth factors, alopecia, infections, or peripheral neuropathy. At all steps, bendamustine scores over the combination of CHOP with rituximab. So we have now a progression-free survival of about 45 months for patients who have received R-CHOP, who have received bendamustine rituximab, as compared to a lesser median progression-free survival for patients who have received R-CHOP, which is statistically significantly different, but the overall survival did not differ in both these groups. The more recent long-term outcomes were presented at ASH in 2017, and that also indicates that the progression-free survival persists over a long period of time, but there is no overall survival benefit which has emerged between bendamustine rituximab as compared to CHOP-R. And so it appears that BR would become the standard of care for the induction therapy. The next question is whether and who should receive maintenance therapy. And this question was first answered in the PRIMA trial, where they looked at patients who were receiving induction therapy of CHOP, CVP, or FCM, and they were randomized to getting either maintenance post their induction therapy with rituximab or were kept under observation for 2 years. Again, at a median follow-up of 36 months, the 2-year progression-free survival for the maintenance arm was 75% as compared to 58% for the observation arm, and this was statistically very significant. So we know that the beneficial effect of maintenance rituximab has been seen irrespective of the induction chemotherapy backbone, and it has also been seen for both patients who were already in CR at the end of induction as well as patients who were in partial response. However, again, this trial at the end of 10 years of follow-up has shown no difference in the overall survival. But if we look at the median follow-up of 9 years, the 10 years PFS is 51% for patients who received rituximab maintenance as compared to 35%. And this actually begins to suggest that almost half the patients who get a good chemoimmunoinduction followed by rituximab maintenance, there may be a subset of patients who are actually getting cured in the frontline therapy of follicular lymphomas. Is maintenance required after bendamustine-based therapy is the next question. And this information comes through a subgroup analysis of the gallium scan, where patients who were given CHOP versus CVP versus bendamustine have been analyzed. The 3-year follow-up of progression-free follow-up for these patients suggests that the number of infectious episodes which are fatal, especially in the period of the maintenance, are actually more on the bendamustine rituximab arm. And so while we discuss definite benefit of rituximab maintenance post CHOP and CVP, when it comes to giving maintenance therapy after bendamustine, the difference in infections was particularly notable during the maintenance and the follow-up phase, and may offset the efficacy that we actually derived from the induction BR regimen for follicular lymphomas. And the way it is explained is that the patients who get bendamustine have a decrease in the CD4 T cell count, and that nadir is reached at the end of induction. And the recovery of these T cells takes about 2 to 3 years in these patients. During that time, if we give maintenance with rituximab, we are also allowing prolonged B cell depletion. And this kind of tips the risk-benefit ratio, which is unfavorable to follicular lymphomas if patients are giving rituximab maintenance in bendamustine. Now, remember, this is not a randomized trial. This is a subgroup analysis. And so it needs thought before we just dump the rituximab maintenance, but it is food for thought for certain. Can we improve the results any further? The E2408 trial did try a 3-arm experiment. It was BR followed by maintenance with rituximab. And the 2 experimental arms were addition of proteasome inhibitor bortezomib to the BR induction. And in the second, it was adding immunomodulatory agent like lenalidomide to the rituximab maintenance. So we had BR followed by R, we had BVR followed by R, and we had BR followed by LR as maintenance. And the 3-year progression-free survival was similar in all the 3 arms, and so it actually did not make any difference. So the current standard remains chemoimmunotherapy followed by maintenance, as I have just discussed. We have various populations. Follicular lymphoma is a disease of older patients. And so one may question whether there is any role of single agent rituximab in these patients, which is ideally used for asymptomatic patients with low tumor burden by the GELF criteria. In the Swiss trial, which was done, they actually did not, they did it for all comers of follicular lymphoma. They used single agent rituximab. And this can be something that we can consider for very elderly patients, very frail patients with significant comorbidities, and for those who are at extreme risk of chemotherapy or who don't accept chemotherapy. The single agent overall response rate in these patients was about 67%. And if we look at the DFS at 5 years, it's about 45%. So at least half the patients would have a DFS at 5 years, which is something to think about, especially in patients in whom we can't give the kind of therapies that I have just described. However, one has to be cautious because single agent rituximab loses its efficacy when lymph node sizes increase 5 centimeters and above, and in patients who present with very high LDH levels. So by and large, most of the patients with high tumor burden would have one of these features, and so not many would be takers for single agent rituximab therapies. Are there any other frontline therapies that we can consider? There is the Relevance trial, which randomized over 1,000 patients of untreated follicular lymphomas to the chemotherapy regimens which we are comfortable with. And the experimental arm was lenalidomide rituximab, which was given for the first 6 months and then was continued for another 1 year in patients who were responding. When we look at the 2 strategies, the overall response, complete response, progression-free survival, and overall survival was exactly the same for the 2 strategies. And at 3 years, the PFS was 77% for the experimental arm and is about 78% for the normal chemoimmunotherapy arms. So despite the fact that they were excellent results. It has been technically called a negative trial because it was designed to show superiority. But at least it gives us one more regimen which we know can be safely and effectively used in patients, whether it is upfront or later when we are sequencing therapies for the relapsed patients. Are there any potential scenarios that warrant special mention? And yes, in follicular lymphomas, there are. If a patient has a high level of suspicion of transformation, these are patients who have significant B symptoms, come with hypercalcemia, have significantly elevated LDH, or high SUVs on the PET scan, I would say anthracycline-based chemotherapy should be used. For patients who have 3B follicular lymphomas, for a long time, we have been treating them as DLBCLs and UPS, the standard R-CHOP for these patients. And for patients who are 3A, treatments such as those used for grade 1 and 2 follicular lymphomas can be used comfortably. There is an entity called duodenal follicular lymphomas, which has a unique underlying biology and a natural history, which is more indolent than even the typical follicular lymphomas. And for these patients, we should not be in a hurry to give them intensive therapies. Actually, no active treatments are required, or at the most, single agent rituximab should suffice for these patients. So if we consider the last 20 years of research for induction therapy of high tumor burden follicular lymphomas, chemoimmunotherapy is cemented. We don't have a universal standard as far as either immunotherapy or chemotherapy is concerned. We can use CHOP and CVP or bendamustine as the chemotherapy, and we can use rituximab or obinutuzumab as the chemotherapy. The maintenance therapy is still optional for the reasons I mentioned, and maintenance is good for patients who are treated with CHOP and CVP, but for patients who are treated with bendamustine, rituximab in induction, in some patients it may do more harm than good, and so a careful thought before we give maintenance to these patients. So eventually we know that follicular lymphomas will relapse, and what would be the next sequence? It kind of depends on the prior treatment that we have given, the duration of prior response that we have seen, the age of the patient at the time of relapse, the comorbidities that the patient has at that point, and the goals of therapy. We know that the patients who will do worse are those who have disease which has progressed within 24 months, typically known as POD 24. And we do not know how best to manage these patients. There is some retrospective data from stem cell transplant registries which suggests superior outcome of transplant strategies in this population, and it should certainly be considered for young fit patients. We also must remember that patients who have a POD of 24 also have a 50% chance of harboring a transformed disease, and that should be looked for before we plan the treatment in these patients. Once we have taken this into account, for most patients who are older, it is a repeat course of immunochemotherapy. For those who have received bendamustine-based therapy, it can be CHOP. For those who have received obinutuzumab, it can be rituximab, and vice versa. I have shown you the results of lenalidomide rituximab, and so this can be brought into a sequence in the second line for patients. It is reasonably well tolerated, except to say that infections and cutaneous reactions are little more than compared to BR. We now will shortly have the PI3 kinase inhibitors. There are 4 of them that have been released for use. The response rates of these run into a range of 45 to 60%, and the average durability of the response is typically about 11 months. They come with a new set of side effects, and so we have to learn how to manage their pneumonitis, colitis, their hypertensions, and hyperglycemias. But this is another group which will find place in sequencing of relapsed refractory lymphomas, definitely after the 3rd or 4th line onwards. We also have the EZH2 inhibitors, which have been approved since the summer of last year for relapsed refractory follicular lymphoma, and will actually find a place lower down in the management of patients of follicular lymphomas. So if we look at the small molecules, then they have an overall response rate ranging between 45 to 60%. The complete responses are not very effective, all being less than 20%. And again, if you look at the median progression-free survival, then it is somewhere in the range of 10 to 11%, which we may not find very meaningful in today's world. So we look at the future, which has its promises and challenges in bispecific antibodies and CAR T cells. And the responses that we see, including the complete responses of bispecific antibodies and monoclonal and the CAR T cells, is kind of encouraging, though it is still in the research modality. So if we look at the two bispecific antibodies that are available, patients of relapsed refractory low-grade lymphomas are there in phase 1 and phase 2 trials, especially the transformed lymphomas. The complete response rates appear to be much more encouraging than we saw with the small molecules. And if you look at the PFS, then at least in 82% of the indolent lymphomas, the responses seem to be ongoing for at least 26 months. These drugs will come with their newer side effects, which include cytokine release syndromes and the ICANS. And we have to learn how to actually look after patients who come with cytokine release syndromes and with the neurological side effects if we have to manage patients who are on BiTEs, as well as the newer therapies, which are the CAR T cells. In CAR T cells, we actually take the patient's own immune cells, we reprogram them to reorganize, and then put them back into the patient to kill the cancer cells throughout the body. So if we look at the procedure, it is something like leukapheresis, removing the T cells, activating the T cells, modifying the T cells and expanding them ex vivo, and then giving patients chemotherapy to make place for these cells and then infusing the modified T cells. So this is more of an engineering feat than anything else, but seems to be actually helping patients who have multiply relapsed, definitely in diffuse large B-cell lymphomas and acute lymphoblastic leukemia. And there is research now on for low-grade indolent lymphomas, including follicular lymphomas. These are some of the CAR T cells molecules which are now available. Most of them are CD19, and we will have better and better CARs available for use in patients in the times to come. So far in the decision making of treatment of lymphoma, what was important was the histology, the stage, the tumor mass, the sites, and the IPI score. We always knew that the patient had to be taken into consideration, and the age, performance status, and the comorbidity impacted the treatments we could give these patients. But in times to come, it is also going to be the physicians who are going to become important, because it's not going to be just our job for all patients. And the biology of the lymphoma, the new targeted therapy, and management of toxicity of these new targeted therapies is going to be a challenge in the best management of patients with lymphoma. So if I have to conclude, follicular lymphoma is the most prevalent indolent lymphoma with a median survival of over 15 years. Patients are typically asymptomatic at presentation, and some of them may never require therapy. But there is a subset of follicular lymphoma at high risk, and we need to find them at the time of diagnosis rather than 2 years down the line. And many of the indices that we have, such as the M-FLIPI, the recurrence with 2 years of chemoimmunotherapy, histological transformation, and young patients less than 60 years are patients who need to be given treatments or whose treatments need to be thought differently. The future research seeks to identify prognostic biomarkers which will be capable of identifying these high-risk patients at diagnosis, like I mentioned before, and not after 2 years. We need to continue to develop targeted therapies, and these patients perhaps will require a different way of treating. We will need tests which will be designed to reduce the risk of histological classification and seek more reliable cures for patients of follicular lymphoma. Research now is in the tumor microenvironment, and we are looking at increased tumor-associated macrophages. And there is some suggestion to say that we will be able to kind of, at diagnosis, find out patients who are at a lower versus at a higher risk of transformation and early progression in times to come. But this is purely in the research mode at the moment. Again, there has been gene profiling, and patients with intratumoral immune infiltration who have either a low or a high immune infiltration suggests that we may be able to find patients who are at an excess risk of POD24 at the time of diagnosis. Again, this is in the research modality at the moment, but it will be important if we can find patients early on and treat them differently. So finally, the key issues will be focusing on biologically targeted therapies. There will be newer monoclonal antibodies, the CD20, which may show more activity than rituximab, especially in patients who are rituximab refractory. There are other several monoclonal antibodies in development against the T and B cells, which are the CD19, 22, and the CCR4. We will have newer antibody drug conjugates. I have shown you immunomodulatory drugs and the kinase agents which are available. And current research efforts are looking at combination of these targeted agents for dual pathway inhibition in the hope to increase the quality and durability of response. And of course, the cellular therapy, the bispecifics, and the CAR T cells may come into the sequencing and will form a part of the armamentarium in the future. So I will end my talk here. Most of the discussions that I have had are in the last 4 chapters of the ICML education book, which was released at the Lugano conference in 2021. And I am happy to take your questions. And if there are any difficult questions, then I will suggest that this book will kind of answer the questions, because most of my presentation is from the last 4 chapters over here. Thank you very much for your patient hearing, and we can go as Dr. Agarwal says.
Thank you, Professor Reena, for that wonderful talk. What an excellent summary of sequencing of treatment in this disease. So we have one question from the audience. Dr. Sumit Mir wants to know, if a patient achieves a PR at the end of 6 cycles of PR, will you recommend going for the rituximab maintenance?
So the answer to CR and PR is actually from the backbone of the chemotherapies that we used earlier, which was CVP, CHOP, and the fludarabine based therapies. And there is no doubt whether the patient achieves a CR or a PR, giving them rituximab benefits the progression-free survival of these patients. In case you are giving bendamustine rituximab, if it is a young patient who has tolerated the treatment well, has no major comorbidities, I would be inclined, because a larger number of patients, as you give maintenance therapy, actually go into a CR at the end of maintenance. And CR is a good surrogate to know that these are the patients who are going to do well in the long term. So I have given you a lot of caution of maintenance rituximab after BR, but this, remember, is a subgroup analysis. It is not really a well-proven management. So with due care, if you feel the patient is going to benefit, definitely go ahead with the rituximab maintenance. If the patient has reasonable amount of disease, or you feel that there can be transformation, which means there is an SUV which is very high, then I would suggest proof that this is actually a histological transformation. Don't continue on just rituximab maintenance and plan for the next line of therapy.
Thank you, Professor Reena. The other question is, how do you suspect transformation of follicular lymphoma, and do you use SUV values to suspect that before doing the biopsy?
Okay, so when a patient either who has been treated comes to you looking really sick, normally when you have follicular lymphomas relapsing, they just walk in, you find some nodes which are increasing, and you know that the disease is coming back. They are by and large asymptomatic even at the time of relapse. So if a patient enters your room and is looking really sick, has a lot of B symptoms, has effusions, has nodes which have suddenly grown in size, these are the patients in whom you will suspect transformation. And when you do the PET scan, if there is an area which is taking up SUVs which are high, and I'm not going to give you a cutoff for the SUVs because really nobody knows what the SUV cutoff is. But definitely when it becomes into double digits, I would suggest that is the area from where you should repeat a biopsy and see to find whether there has been transformation. And again, if you have not treated these patients with CHOP upfront, if you have the doubt of transformation, CHOP remains the better treatment for patients who have transformed. So these are the patients in whom you would kind of suspect transformation.
I thank Dr. Mona Vijayaran for that question. Dr. Krishna Ratnam has a question regarding autologous transplant. So you told us that those patients who are POD, you prefer autologous transplant. Besides that, are there other patient group where you go for autologous transplant in relapse setting?
So a young fit patient is one where I would consider a high dose chemotherapy and give them this option of autologous transplant, especially in those who have transformed lymphomas. Those are the patients, again, in whom if you have achieved a good response, it would be something to consider by going ahead with high dose chemotherapy and autologous transplant. The next question always comes up is allogenic transplant. I think in lymphomas, the dictum more or less is the treatment related mortality is so high that moving on to allogenic transplant is, according to me, a no-no. I hope there are not too many transplanters here. I don't believe in allogenic transplant for these patients. I think the newer modalities, as and when they are available, will take over, and we will have bispecifics and CAR T cells which will do the work at that time.
So Rina, as of today, if you have a young person who has a relapse refractory follicular lymphoma, treated with chemoimmuno and then treated with, say, autologous transplant, and if he comes back, what do you do with him today in Mumbai or in Kolkata?
So I actually thought the lenalidomide rituximab was something that has given reasonable outcomes. Of course, that is in the upfront setting. So we are not going to have a 77% progression-free survival of these patients at the end of 3 years. But at least we can buy time because the monoclonal, the bispecifics seem to be on the horizon. And we are already getting them at compassionate access for DLBCLs, and the likelihood is that we may get them for patients who are actually relapsing after follicular lymphoma, especially if they have been transformed. We will be able to kind of project. So anything that will give us 2 more years of progression-free survival in these patients is important. If we can get the PI3 kinase inhibitors, then that also gives us at least a year, if not more than that. So I would try to get one of those drugs also for these patients. And we would have, of course, by now used up the chemotherapeutic drugs, the obinutuzumab as an immunotherapy, and the rituximab maintenance for a person that you have just described. So it's going to be waiting for the new drugs. And while you're waiting for the new drugs, keep these patients in whatever kind of a progression-free survival you can, with the use of maybe lenalidomide-based therapies, obinutuzumab if you haven't used it, and the old chemotherapies. In case there is transformation, you can use everything from GDP to ISHAP to ICE to RICE, whatever.
Thank you. 2 quick questions. What is your preference, BR or R-CHOP?
I have been very comfortable with BR because most of the patients are older and the toxicity profile and the efficacy is far superior. I have been honestly using rituximab maintenance, but this particular reading has for some time has been causing a little bit of doubt. So if a patient on BR is reluctant for maintenance therapy, I encourage them. Otherwise, I discuss with them. And in older patients, avoid rituximab maintenance, but BR remains my now, what is going to be important is to start looking at follicular lymphoma patients holistically, which means if we are going to look at these patients who in future will require CAR T cells, then maybe we will have to think about giving BR to all our patients upfront. for patients in whom we will kind of jeopardize their T cells and have a problem when it comes to CAR T cell therapies in these patients. So there is a thought process now that follicular lymphoma treatments, at least where all these treatments are available, has to be thought more thoughtfully. And so bendamustine may not for a long time remain the kind of drug that it has been in follicular lymphomas for the last decade or so. That is one process which needs thought. If the patient has the slightest doubt of transformation, or like I said, if the patient is tending towards 3A, 3B, then of course, or the patients are very young, I would kind of prefer a CHOP-based regimen, give them the rituximab maintenance, get the best progression-free survival, hope that at least 50% of these will go on beyond 10 years without problems and would get taken care of. And in the remaining, we will have the other drugs which will eventually come in and we can sequence them more judiciously.
Thank you, Professor Reena. We have run out of time, but just answer one more question. Dr. Mustafil Karim wants to know, he has seen a patient who after 5 years of CLL developed multiple myeloma. Patient was treated with BR. Will you call it a transformation or these are two separate diseases?
Okay, so for transformation, I will put it as an aggressive lymphoma, and I will call the multiple myeloma another disease, but I may be wrong. I think we need more work at the basic level and somebody with more basic information who can give a better answer.
Thank you, Professor Reena. Unfortunately, that's all what we can accommodate. And
thank you, sir.
Lovely lecture, very enjoyable, very educative. I'm sure everybody has benefited. Thank you. And thank you for being with us. We move to the second segment of this webinar. Those of you who have joined late, today is the last day of this marathon 5 days webinar series conceived by Dr. Reddy's, executed by Mumbai Hematology Group, and basically covering the advances, publications and presentations which have taken place in last 9 months of the current year. From the house of Dr. Reddy's, you have a wonderful molecule, rituximab by name Reditux. And as you know, when we're discussing lymphomas, this forms a sheet anchor of our treatment of CD20 positive lymphomas. The second segment is the panel discussion, which will be very exciting. And the title is very, very exciting. Dissecting the biology of DLBCL. How close are we to a clinically validated molecular platform? Very, very interesting. And to moderate this, we have Dr. Gaurav Prakash. You all know him, additional professor, Division of Hematology, Department of Internal Medicine, PGI, Chandigarh. And we have a galaxy of wonderful panelists. We have Dr. Amanjit Bal. She's professor, Department of Histopathology at the very same institute, PGI, Chandigarh. She's Master's Molecular Pathology and Genomics from Barts Cancer Institute, London. We are grateful to you for joining us, and she is going to play a key role in this discussion today. Dr. Darshana Rane, she's my colleague in Mumbai, consultant medical oncologist at now become a very, very prestigious hospital, Nanavati Super Specialty Hospital, Vile Parla, Mumbai. Dr. Meet Kumar, who is consultant hematologist, hemato-oncologist, bone marrow transplant physician from Fortis Memorial Research Institute, Gurugram. And then we have Dr. Pankaj Tentia, who is consultant clinical hematologist, assistant professor, Department of Medical Oncology at Acharya Tulsi Regional Cancer Center, Bikaner. Dr. Chinmaya Pani, who is medical oncologist, Apollo Hospital, Bhubaneswar. Dr. Suhas Agre, medical oncologist, MPCT Hospital, Sanpada, Mumbai. And Dr. Sanket Shah, consultant hemato-oncologist, stem cell transplant physician at HOC Vedanta, Ahmedabad. So thank you, and over to Gaurav.
Thank you very much, sir, and good evening, everyone. Now I would like to share my screen.
Kalpesh.
Yeah. So again, good evening, everyone, and this is an exciting topic. It's not often that we get to discuss the pathology aspects of DLBCL amongst clinicians. And we are lucky that at the last moment, Professor Amanjit Bal, she agreed to be a part of it to make it easier for us to understand the topic as well as to take the discussion further. I'm very much thankful to Professor Agarwal for selecting this topic and as well as giving an esteemed panel to me so that we can have a fruitful discussion on this topic, which is very much needed. So all the panelists have been, introduced to you. Dr. Chinmay just recently informed me that because of an emergency, he had to go. So Dr. Chinmay has excused himself, and we have just the panelists available. I hope so. So I'm Gaurav Prakash, and just in addition to the introduction, I'm very glad to tell that recently a new department has been created at PGI, which is Department of Clinical Hematology and Medical Oncology. And which is a good news for our patients, our trainees as well. So I would like to share it with you. And with this, I think let us begin a talk about DLBCL. DLBCL is always fascinating. Whenever we see DLBCL, we always believe that this is something we can win over. But time and again, it keeps humbling us. There are a few basic points regarding DLBCL. We know this is one of the common subtypes of lymphoma, rather commonest in our country. We also know this is highly chemosensitive. But despite that, we are able to just cure something 50% or north of that number of patients with DLBCL with the currently available treatment options that we have. One of the reasons and one of the point on which most of us agree, both pathologists and clinicians, that DLBCL is quite heterogeneous. It is not the same disease, although we may have the same name on the pathology report. It is heterogeneous from the point of clinical response. It is heterogeneous from the point of pathological finding, and it is definitely heterogeneous from the genetic point of view. As far as treatment of DLBCL is concerned, we all know the major thing which happened, unfortunately, it happened 2 decades ago, and nothing much changed in the development of rituximab for the management of DLBCL. This is a graph which is very exciting for most of us. And rituximab, before in the pre-rituximab era, we used to have survival long-term cure, quote unquote, around in the range of 40-45%. But now I can very safely say we have improved the overall survival by the magnitude of 15 to 20%. And now around 60% patients are able to live longer without recurrence of their disease, and which is a very, very exciting thing. However, being somebody who is very much interested in this disease, I see this gap between 100 and 60%. There are 40% patients who really need something better than R-CHOP chemotherapy or a better way of identifying them before so that we can treat them better. So with this, now I open the discussion to the whole panel. I think initially I will invite comments from Dr. Darshana and Dr. Meet Kumar. And this is actually just to understand the proportion of DLBCL patients that they see in their clinical practice. I'm definitely not looking for an exact figure. This is a ballpark estimate, and you can just share so that we have idea, because all the panelists come from different parts of India. So Dr. Darsh, Dr. Meet, Bombay, Delhi, and Dr. Then Pankaj, and everybody can contribute.
Thank you,
So
Dr.
let's
Gaurav.
begin with Dr. Darshana.
Yeah.
If you can turn on your video, Dr. Darshana and Dr. Amanjeet also. Dr. Meet Kumar and Dr. Sanket, everybody, can you just chip in and eyeball?
So thank you, Dr. Gaurav, and thank you, Agarwal sir, for this wonderful panel discussion, for this opportunity. So what I would say is, like, the percentage of DLBCL out of the total lymphomas in the clinical practice, the kind of patients that we see at Gurugram at Fortis Hospital, would be to the tune of roughly 40 to 45%. And yes, we see a lot of low-grade lymphomas. The high-grade lymphomas are pretty less common. Burkitt's very rarely.
Okay.
But yes, of course, DLBCL to the tune of 40 to 45%.
Thanks, Meet. We are collecting the just a ballpark figures. So let's move on. Dr. Sohas Agare.
So in my practice, it would be somewhere around 40 to 50% of the DLBCL of total population.
Okay, so around again the same figure as experience in Gurugram. Dr. Pankaj at Bikaner, what is your experience?
We have around 40% or less, and moreover, we have Burkitt lymphomas. In these 3 months, we are getting a lot of Burkitt lymphomas, and few of Yes, a lot of kids we are getting a bucket lymphoma from Punjab and Haryana
Okay,
side.
so I mean, so probably we would be discussing more on, not exclusively on adults or more than 12 years of age. So that would, we know that lymphoma in kids is different than adults. Dr. Sanket, and then I will come to Dr. Amanjeet in the last.
I think it's around 40% or something like that.
Okay, so I think we heard the clinicians. So as far as their clinical office practice is concerned, let's go to Professor Amanjeet, who is a lymphoma pathologist and oncopathologist at PGI. Madam, in your understanding, what is the number of proportion of DLBCL of all NHL?
So we are encountering more than 50% of our lymphomas as high-grade B-cell lymphomas, and most of them are DLBCL. So our percentage is, higher for DLBCL as compared to other lymphomas.
All right. So I think we can see a trend is there that so at least because Dr. Amanji deals with diagnosis, so it is likely that many of those patients who are diagnosed with high-grade lymphoma may not turn up for therapy for various reasons, which we are not discussing. But it seems that the clinicians are getting somewhere between 40 to 50% of patients who are having DLBCL. But definitely at the diagnosis side, it seems the number is north of 50%. Let us see some data. We heard Professor Reena Nair just before this discussion, and this is a beautiful paper published by her and her group. And this is a compilation of studies published from India and the rest of the world. And these are the three major series of lymphoma published from India previously. So if you see in this series, except this outlier by Dr. K. Naresh, we can see 46%, 50%. So around half of the lymphoma were diagnosed as DLBCL previously. I have in the red color, I have also highlighted data from Thailand. In Thailand also, you can see it is around 50% of the patients. Now, let us compare this data from the developed world, which is in green color. You can see USA, Korea, and Japan, both Western and Eastern hemisphere world. The first percentage is just in 30s. So it's very much clear that DLBCL proportion is lesser in the Western countries. There may be a biological and geographical variation. However, there is a possibility as because of longevity or higher life expectancy in these population countries, more patients are living longer so that they can develop indolent lymphoma, and that might be a confounder. So I think 50%, the estimate of the analyst is very much correct, and we are having around half of the patient. In the same paper by Professor Reena Nair, there's an estimate, there's a projection of lymphoma patient. Currently, we are over here, and in a decade to come, we are likely to have around 40,000 patients of DLBCL in 1 year. This number is mind-boggling. So we really need to, come together and do something about DLBCL because numbers are rising. Definitely, lymphoma is not a disease whose numbers are declining in the world. Other cancers might be declining. So coming to all panelists on the topic of concerns, that how do you do prognostication of a DLBCL, newly diagnosed DLBCL patient in day-to-day practice? So let us go to the clinician because they will be handling this aspect. Let's start. Dr. Pankaj, Meet Kumar, anybody?
So once again, thank you so much, Dr. Gaurav. So the routine prognostication, what we are doing right now is the IPI-based prognostication. And to a certain extent, hello, am I audible here? So to some extent, evaluation of the IHC-based marker for the double expressor lymphomas. If that's a high-grade lymphoma, that's a high KI lymphoma, then we do BCL2, BCL6 evaluation specifically looking at that. But other than that, limiting it to the IPI score index.
So traditional IPI and top up with a ISC-based cell of origin, you want to say that. Is it correct? I think we lost connection maybe with Dr. Meet. Dr. Swahas, what are your views?
RIPI with cell of origin.
Yeah. Swahas, can you just tell us quickly?
So clinical practice, it would be IPI score. In addition to that, normally we do IHC for a MYC BCL2 expression, overexpression, and if it is an MYC overexpression, in that case, we do FISH testing for MYC, then translocation as well as BCL2 and BCL6.
Oh, all right. So you do this tailor-made approach of, just cost saving. You do initially ISC, and in suspecting cases, you do for translocation. That is great. Any other biochemical marker that, office-based bedside sampling you can test for a new practice? Right. Why I'm asking you, because we recently found, this is the data, we recently found in our practice at PGI that C-reactive protein and interleukin-6, these are the two cytokines which have clearly shown as a good predictor of survival, both overall and event-free survival. So CRP is something which we have included in our regular prognostication panel, and IL-6 is difficult to do. It is a cytokine. So that still remains in the realm of research. Now, this is very much clear. The data is there. For last 15 years, we know cell of origin
This is at the
important.
time of diagnosis? Sorry.
At the time of baseline diagnosis, high CRP more than 30. The cutoff is 30, is not 10. The standard cutoff is 10, but prognostication of lymphoma comes at 30. So we all know cell of origin. All of us largely rely on IHC. So my question to you is that there are so many algorithms which can tell you about cell of origin. So what is the preference by you or the pathologist at your end? And in the end, I'll ask Professor Amanjeet to give a comment on this. So do you use any specific one, or all are almost same? Dr. Sanket and Dr. Darshana, if you are there.
It's Hans algorithm which is common.
So even in, I'm Dr. Darshana, even in our hospital, we choose Hans because it was the earlier developed algorithm, and the markers which are used, all the BCL6, MUM1, they are more, and CD10 are more easily available compared to the other markers. So the commonly used algorithm is the Hans. One more thing about the previous question I wanted to mention, we do just like the way you had said for the biochemical markers, we obviously for DLBCL, we know we should see the LDH and whether the patient is in tumor lysis, and that's how we try to make our choice in the treatment.
So this is part of IPI.
It is the part of IPI.
We got the point, because all panelists agree that they do IPI as well as cell of origin.
Yes.
I think now we are with this point of consensus, we are gravitating towards how to reach at cell of origin. It is clear almost. There is no debate about that cell of origin is clearly prognostic. These 4 graphs which were published in 2009, and even many more graphs before that, they have clearly shown the segregation of progression-free and overall survival with respect to cell of origin. So that is undisputable. What remains disputed, or maybe a work in progress, that how to identify cell of origin in an optimal way so that we can identify the patient better. So I'm just showing you these 4 algorithms, and there are many more. There are around 9 to 10 different algorithms. So here I would like to invite Professor Amanjeet and her thoughts on that. Madam, what do you think that the reason behind using Hans, almost universally, and the other regimen, while some other regimen have shown better prediction of cell of origin in comparison to gene expression profiling?
WHO is recommending Hans algorithm. So it's easier, and it's a binary system, divides into GCB and non-GCB, and you have to use only 3 antibodies for this. So we tried to compare with choice algorithm using 2 additional antibodies, one for GCP phenotype and additional for ABC phenotype. However, there is a universal problem with these antibodies, GCET1 and FOXP1. They didn't work well in formalin-fixed paraffin sections. So probably because of these technical issues, so choice algorithm is not very famous as compared to the Hans algorithm. So that's why university people are using Hans algorithm.
Okay, ma'am. So I think all of us are aware gene expression profiling has clearly segregated. It remains largely in the realm of research. We most of us do not have a real-time or accurate access to gene expression profiling. So really, we need to look for other platforms, or the newer, rather less intensive and less bulky genetic platforms, which can probably predict or replicate the results obtained from gene expression profiling. So I think we have discussed about IHC part, and almost all of us are clear that Hans algorithm is over there, which is clearly predictive. And FISH is there, which is almost accessible to most of us. I think majority of the practitioner, they take a step-up approach. They initially go for IST and expression of MYC and BCL proteins. And if they find it, then they escalate it for FISH testing. And if it is double-hit, definitely, then it is the decision of the clinician to treat in a different way or not. Gene expression profiling. Now, we come to the point number 3, which is selective genetic platform.
LYMPH2CX is basically a RNA-based method, and it's a proprietary for a nanostring company. They have their instrument and they have these kits, and they are using a 20 gene signature. 8 genes are for ABC phenotype and 7 genes for GCB phenotype, and 5 are housekeeping genes. The advantage of this over gene expression profiling is this can be done on formalin fixed paraffin embedded tissue also. And second advantage is you just take out or extract RNA. There is no need to amplify it. Just direct RNA can give you results. So based upon this gene expression profiling, they have a software which divides it into GCB and ABC phenotype. And I think approximately 20% cases still remain unclassifiable using this LYMPH2CX assay.
Yes, madam. So what we clinician understand is that RNA is a highly labile molecule. So for example, if we decide to send it to a place or center or laboratory where it is done, so should we send a tissue, fresh tissue or paraffin, or we extract RNA and RNA should be shipped?
So paraffin embedded tissue will be better because transportation of RNA will be difficult. So they can extract RNA themselves. So okay, they are using, so this is the only advantage of this, because it can use RNA extracted from paraffin-embedded tissue.
Okay, so I think which is a big advantage because gene expression profiling for the optimal result would need a fresh tissue. And apart from limitation of its high cost and bulkiness, this is another limitation. So any of the panelists who are working in clinics, are you using this platform in any laboratory in the corporate big hospitals? Any of you can take up this question. Unmute yourself. I think Dr. Meet, you are mute.
I'm so sorry. So am I audible now? I'm so sorry. So
Yes,
like I have
you go
not
on.
used this platform, but I'll be really encouraging to understand and know more about this platform, especially like where is it done and like what will be the cost implications of the same. It'll be really interesting to know. Personally speaking, I have not used this platform. Is PJ doing it?
No, PJ is not doing it. So, I mean, the platform costs around more than 1 crore if we have to do it in-house.
For testing, ma'am, for testing, as in like for the testing for the patient.
If you have to test it, I think it's around 3,000 to 4,000 rupees per sample.
And that will include all the 20 genes, is it?
Yes, all 20 genes.
And where is it done?
I think that's a very important.
So I have a number of somebody who used to come to PGI if they want. I mean, if I can share the number.
That's some personal lab, that means.
Yeah.
No, actually, so I think what I can understand is that the company is NanoString. NanoString is a company which works on genetic platforms for various tumors, and DLBCL is one of them. And they have developed this platform for testing. So what I am still, and I would like to learn from other panelists and other speakers, that their accessibility to Lymph2CX and NanoString platform in India, but the representative of the company have approached bigger hospital like PGI, and they said that's why Madam is providing this information. The cost of setting up it will be around 1 crore is the cost of equipment, and then running it there will be kits which will be provided by the company. So although it remains very attractive, I would like to show you the same thing, Lymph2CX and its concordance with IHC. ISC we have accepted because it seems to be the poor man's gene expression profiling. But if you see the concordance, so by hands, all of these 100% cases, they were GCB subtype. But when you applied Lymph2CX, which is the genetic platform, found out that only 66% of these patients express genes related to GCB. If you see the activated B cell, by Hans algorithm, all of these patients were activated B cell subtype, but when you applied Lymph2CX, only 80% patient had genetic alteration, which is commensurate with ABCs type of DLBCL. So like 33 and 20% discordance. This is a big number, especially if you plan to alter your therapy with respect to the cell of origin, which can also be done or maybe debated. So I think there remains a big area of need of identifying something better than IHC today. And Lymph2CX appears to be the platform which is closest to GEP, which is available to, which can be quote unquote available to us in India. Definitely in Western countries, it is much easier to obtain this regimen. Now, this is what I want to show. There's a new study, recent study, which is from some Eastern country, maybe Malaysia, where they said that survival of patient. Again, same set of patient. Initially, only ISC was done, and they found that after R-CHOP chemotherapy, there was no difference between the survival because they used this algorithm. And when they tested for 5-year DFS, this is overall survival. DFS, they could found there was some difference. However, on the same set of patient treated similarly, when they applied Lymph2CX, the separation of survival graph for both overall survival and free survival was excellent. So what this paper, which is a clinical real-life paper, it is not supported by any industry, is a patient care paper. It clearly showed that we can really do better by using a better genetic platform if the cost and availability can be feasible. Now, this is a very interesting slide, which is helping us to identify which subset of DLBCL are likely to show maximum discordance in between this algorithm and a genetic testing. Would you like to just put some light on this, that why patients who are having CD10 negative and BCL6 positive, this kind of ISC spectrum, they are more likely to have a discordant on genetic profiling? And endoscopic biopsy.
Okay, so the problem is, the Hans algorithm says do CD10 first. If it is positive, then call it GCB. If it is negative, then you do BCL6 and MUM1. So if it is BCL6 positive, then call it GCB. And if it is MUM1 positive, then call it ABC. So problem is, one is with the BCL6 immunohistochemistry, it shows quite heterogeneous results. And it's not only, in a particular center, it's a universal problem again. And second set of cases is where you find both BCL6 expression as well as MUM1 expression. We are calling those as ABC phenotype, but how do you explain BCL6 expression in those? So these are the two sets probably which are showing better,
more
what you can say, more separation in the
genetic.
Yes, so between the gene expression profiling and IHC.
So thanks, ma'am, for explaining this. So for example, now in this graph, you can see that this bar is of discordance, discrepancy. So if there is a patient of DLBCL clinic who is having CD10 negative and BCL6 positive, and because of this, the patient is GCB, then there is a 50% possibility that this Hans algorithm result may be discordant from gene expression profiling. So this subset, I think we all daily read these reports in our clinic. So if you are having this subset, probably you can estimate that there is a possibility if you have access to more genetic testing or something else, probably go for it. The second subset, as Professor Manjeet has said, that if you are having low positivity, which is like 30% or below of BCL6 and MUM1 both, because BCL6 will take it towards GCB and MUM1 will take it towards ABC subtype. So again, you can see discordance is around 30%, 1 in 3. And this is a very, very understandable point that endoscopic biopsies are usually fragmented and small. So maybe the genetic material or the staining may be challenging. So these are the three subsets which, while we are sitting in our OPD, probably we can have a closer look as far as further elucidation of cell of origin is concerned. And with this, I think time is running out. Also, we are coming towards the end of this discussion. So, madam, you are a senior pathologist, so we would like to learn from you that what limitation do you see? Why, with only 4,000 and 5,000 rupees kit, this LYMPH2CX, which seems to be very good prognostically, is not widely available? And second, then I will go to my clinicians, that what limitation do you see on the clinical side?
Limitation is only one is the cost factor, and second, pathologists are very easy and comfortable with immunohistochemistry and fish-like techniques. So they are not trained molecular biologists. So this needs some of a molecular biology experience also. Otherwise, there's no harm in doing it.
Okay, no. So, madam, so that is one statement that you don't see no harm. But are you convinced as a molecular pathologist with this platform and its veracity of a tool to find the cell of origin?
Yes, I think so, because initially it started with gene expression profiling, which is 20,000 genes, and then this one is around 20 genes. What we are doing is 3 genes. How 3 proteins will be able to tackle all the heterogeneity? So I agree with this platform. So probably it's more able to decipher this heterogeneity in DLBCLs.
That is a very fine point, madam. And our clinician friends, Dr. Sanket, Dr. Meet Kumar, and Suhas, and Dr. Pankaj, because you all work in different cities and different setups. So what limitation? I think let us discuss. It's not about an exam or being right. So let us discuss the limitations, and so that we can understand each other.
No, it's like one is availability, second is our knowledge, and then third is its applicability.
Okay.
So I think
next,
first
Dr.
of all,
Suhas. Yeah, we got your point. Thanks. Suhas.
So I think now since we came to know that this is it would be available, most of the panelists, even they were not knowing these things particularly, availability. I think availability would be the main concern, and cost has been now it has been clear that it's not that kind of cost very much to offer.
If available. Dr. Meet, what is the situation at Gurugram and in corporate hospitals? Mute again. Please unmute. Yeah.
So what I will say is, rather than the question of being at a corporate hospital, I would rather say that it's a question of applicability, as Dr. Sanket was trying to say probably. Then that means that what are we going to derive even if we get a positive or a negative result? Are we going to upscale or downscale the treatment, and is it justified, and are there sufficient number of trials that have proven that upgrading the treatment to a higher intensive regimen, if it is a double hit or triple hit lymphoma, and that's going to significantly impact the outcomes? Whether that data is mature enough, that's what the question is all about, probably.
All right, fair point. I think I'm going to come to this point as my last slide. So while looking for it recently, just this year, 2021, very recently in Hematologica, there was a paper. So apart from having that 20 gene nanostring platform, they came up with this kind of only 3 gene, and doing 3 gene in laboratory should be very difficult. And they clearly showed that it can improve risk stratification in patients with DLBCL. People are ready to identify the genetic markers. If you look at AML, ALL, and other multiple myeloma, the genetic markers are much more refined. So in this paper, you can see very clearly the patient who had low expression, the survival is almost 90-80%, and high expression is way down. And this is that signature which can clearly, very statistically significant prediction of poor survival if the signature of these genes were over there. So this is something we had tailored down from 20,000 gene of gene expression profiling to 20 nanostring, and now maybe probably 3. But this is only just one single paper, needs more validation. And now, every conference we hear about artificial intelligence and machine learning. So it is also coming with respect to gene expression profiling. It is also coming with respect to ISC, just to automate the process and make it more homogeneous. I think this is very much there, and we can just talk. I'm just mentioning it for the sake of reference, not going to discuss about it. Last point with our clinician colleagues. So, do you treat the holy grail question, your cell of origin patient, GLBCL, GCP, and non-GCP differently? One by one, quick answer, and we conclude then. So, starting with all 4 of you, please, can you tell us? Dr. Darshana, are you still there? I cannot see you.
By the cell of origin, we don't really treat GCP and non-GCP differently.
Okay.
And,
fair enough, I think. That moving to Dr. Pankaj.
Actually, we are not treating like this whether patient is of GCB or non-GCB. But if in IHC it is mentioned that it is a GCB or a non-GCB disease, then we treat him accordingly. But now you really have opened our eyes, and we will try to go for lymph-2X for further management of these patients,
in case it is available. So moving to Dr. Meet, Dr. Suhas.
Again, I'll say the answer is more elaborate in the sense it depends essentially on how we counsel the patient and how willing the patient is to accept in the lack of conclusive data. So that's again the point is there is no hard evidence to suggest that, okay, upgrading the treatment to double hit, triple hit lymphoma. I just want to change the topic from cell of origin to double hit or triple hit lymphoma and say that upgrading, whether it actually helps or not, there is some soft indicators, but whether it's hard, there is no hard data to support that. So as of now, we are not doing that.
We are not. So, okay, we have 3 unanimous decisions. Dr. Suhas.
So I think now we are quite aware that these are the 2 different, definitely the prognostic factor basically. So GCB is likely to do well as compared to the non-GCB. And then the second thing would be whether it would have any kind of clinical application per se, because normally R-CHOP will be the standard of the care for GCB type, but we want to have some additional insights for the patient who are having maybe non-GCB subtype, maybe some addition of some novel treatment like maybe the lenalidomide or maybe ibrutinib or the maybe the bortezomib, but we don't know what would be the result basically and the toxicity profile, maybe some particularly for some elderly people also.
Prakash,
okay, so
2 minutes to conclude, Prakash.
Sir, this is the last slide, and I think there is a great amount of concurrence between all the panelists that cell of origin is very much needed. We need this information. This is highly prognostic, but there is a very clear evidence in our hand, including the latest Phoenix trial, which is ibrutinib, the new, including that the efficacy of R-CHOP plus over the R-CHOP or any cell of origin, activated B cell included, is not there. You can have some post hoc subset analysis where they may show some benefit and all, but there's a clear evidence that the R-CHOP plus strategies, they are more toxic. So therefore, you can see across the country, in parts of the country, everybody is still, wary of using a R-CHOP plus strategy just on the basis of
Realme ka password.
So with this, I think I thanks all the panelists for their engagement and giving the valuable insight. My special thanks to Dr. Professor Aman Bal, whom I requested, because without her contribution, this discussion would have been, suboptimal. So thank you, madam, and all my panelists, as well as just for giving this opportunity to all of us to convene and discuss this topic. Thank you.
Thank you, Dr. Gaurav. Thanks our guest panelist, Dr. Amanjit Bal, and of course, all our colleagues from various parts of the country for joining. This was a wonderful discussion and was very valuable. We move on to the third segment of this panel, this webinar today. So, as you know, this webinar, which is 5 days long webinar, today is the last day, was conceived by Dr. Reddy's, executed by Mumbai Hematology Group, and named Year in Review because we are basically covering what was presented or published during last 9 months of the current year. From the house of Dr. Reddy's, you have this important molecule that is rituximab, available as ready text for the treatment of CD20 positive lymphomas, the subject of discussion today. The third segment of this webinar is the debate. And from follicular to DLBCL, we now move to the mantle cell lymphoma. Two important aspects of mantle cell lymphoma, where some do and some don't do, are autologous stem cell transplant upfront and rituximab maintenance. So we're going to debate about this. In favor is Dr. Ankur Bahl, is Senior Director, Fortis Memorial Research Institute, Gurugram. Against is Dr. Ghanshyam Biswas, Consultant Medical Oncologist, Executive Director, Sparsh Hospital, Bhubaneswar. So let's begin with Dr. Ankur in favor of the idea.
Yeah. Thank you so much, sir. And I'm sharing my slides. So, yes. I hope my slides are visible right now.
Yes.
Yeah, thank you so much. I'm just switching off my video because of some poor connection. I'll make it on. So the debates are the most important part of any seminar, and it could turn into a most controversial also. But the topic which is being given today is mantle cell lymphoma always require upfront autologous stem cell transplant and rituximab maintenance. So my answer is yes. My answer is yes, because if rightly treated at right point of time in a right patient, followed by rituximab maintenance, and Dr. Biswas is smiling at me, so it gives advantage in the form of OS, PFS, and how it does it, I'll be just putting evidence to it. And So just a basic thing, mantle cell lymphoma is one of the BNHL, but it has a variable course. So in minority of the patient, this is a disorder which may not require treatment, and it may go untreated for many years. We have to identify such patients, and we have pathological biomarker which actually tells us which patient may go or how the disease may go. And other patient, as an aggressive NHL variant, it can have a virulent character and may not respond to a standard treatment. So long enough, we have the data which says the MIPI, the Mantle Cell Lymphoma International Prognostic Indicator, the very famously MIPI index, we divide into low risk, intermediate, high risk, and our overall survival and median survival depend upon this risk. But very recently, we have 3 pathological markers, very simple, Ki67, not very simple as SOX11, and TP53, which identifies which are these aggressive NHL and which is this not that aggressive mantle cell lymphoma. So coming on to the treatment of MCL, so it goes, I would say, the myeloma way, the induction, the right induction, the right consolidation at appropriate time at right CR. The first CR may not be after 2 or 3 lines, and then the long-term maintenance, which has been showed in LYSA trial, which I'll be showing you, that it gives the survival advantage both in the form of PFS and OS. So which are the patient which should get autologous stem cell transplant, which are the patient which should get maintenance rituximab. So it depends upon mainly upon the fitness of the patient, which is ECOG performance status, the age of the patient less than 60 or even less than 65 if they are very fit, and most importantly, what regimen you have followed in induction therapy, whether it is a hyper CVAD or the common chemotherapy, immunotherapy, which is R-CHOP or DAB or many other protocol, or you are relying on the most simplest and the easiest one and the most good one, which is bendamustine rituximab, if given properly, may not require maintenance rituximab as per the literature. So the treatment goes, in occasional patient we may not treat. In younger patient who are less than 60 years old with a good performance status, which is ECOG less than 2, so these are the patient who can be given a hyper CVAD followed by autologous or an R-CHOP or a RDAB followed by an autologous stem cell transplant, then maintenance rituximab, which gives a high response rate. Toxicity, as if we choose a hyper CVAD or an R-CHOP, that's a different part of our talking. But these patients who got autologous stem cell transplant followed by maintenance have a advantage with the PFS as well as OS. And older patient with a good performance status, we may or may not give autologous stem cell transplant. So outside the clinical trial, these are the three main ways we treat MCL: conventional chemoimmunotherapy, R-CHOP, BR alone, followed by maintenance rituximab; conventional chemoimmunotherapy followed by an autologous transplant, followed by maintenance rituximab; or just an intensive or non-intensive chemotherapy with or without autologous transplant. So consolidation is a treatment which is given after a maximum response has been achieved, and the outcomes, it clearly says that the outcomes are better for those who attain CR prior to autologous transplant than those who are PET positive after a good regimen. So even there is a data which says that if you have given bendamustine rituximab, it should be followed by a rituximab and cytarabine before taking these patients for an autologous transplant. So now I'm coming on to the straightaway evidence. This is the first phase 2 study of bendamustine rituximab and rituximab cytarabine published in Britain Journal of Hematology, which clearly shows that the CR which was achieved prior to stem cell transplant was 75%, and which rose to 96% at the end of study. Of the 15 patients who were evaluated for minimal residual disease after autologous stem cell transplant, 93% achieved MRD negativity after transplant, and after a median follow-up of 13 months, I know it is less, but both PFS and OS were close to 10%, which was 96%. This is a blood paper, the real-world data on the primary treatment of mantle cell lymphoma, the Nordic Lymphoma Group observational study. So this had a huge number of MCL patients, which was around 1,400 patients, and clearly says in multivariate analysis that those patients who had underwent autologous stem cell transplant followed by rituximab maintenance, so rituximab and autologous stem cell variants were independently associated with the improved OS in a multivariate analysis, not in a univariate analysis. And the hazard ratio of rituximab as well as autologous stem cell transplant was 0.66 and 0.55. So very comprehensive data, affirmative data, which saying that autologous stem cell transplant followed by rituximab maintenance gives an edge both in OS in a multivariate analysis. So this is a JCO paper which says that even RIC, allogenic hematopoietic stem cell transplantation in a chemotherapy sensitive mantle cell lymphoma. So what should be we are not talking about whether autologous stem cell should be done or not. This paper is purely talking about what should be the transplantation timing and modality. And it clearly says that for patient with chemotherapy sensitive MCL, which they are, the optimal timing of hematopoietic stem cell transplant is early in the disease course. That means if you get an CR early with first line of therapy, go for it. It's not a debate about whether to go or not. It's about when to go. So there are papers on it which defines what is the right time to go for an autologous stem cell transplant. So they say do it in a first complete remission rather than waiting for the relapse and go further giving 2 lines or 3 lines of therapy in a relapse disease, which may not give a long-term remission or which may not give a high survival. So this is again a JCO paper of 2011, which said that MIPI index correlate with the the outcome of the stem cell transplant. So we have papers which are further defining what are the outcomes, when to do, when not to do, and what is the first timing of transplant trial. So coming on to the rituximab after autologous stem cell transplant, this is a LYSA study, the Lymphoma Study Association trial, published in Blood Journal, NEGM, with a randomly assigned paper of 240 patients to 3 years of maintenance rituximab versus observation after 4 cycles of induction therapy. So the LYSA trial, which was a huge median follow-up of from randomization, which was close to 4 years, 50.2 months. So starting from randomization, the rate of event-free survival was 79% in the rituximab group versus 61 in the observation group, clearly saying that maintenance rituximab gives an edge. The rate of PFS at 4 years was 83% versus 64%. Significant value, p-value. The rate of overall survival was 89% in the rituximab versus 80% in the observational group. So it clearly concluded the LYSA trial that rituximab maintenance therapy after autologous stem cell transplantation prolong event-free survival, prolong progression-free survival, and overall survival among patients who are diagnosed with this disease who are younger than 66 years of age. So it's clearly mentioning stem cell transplant, clearly mentioning rituximab maintenance. So this is again NEGM publication showing treatment of older patient with mantle cell lymphoma. So it was again a randomized study of 274 patients more than 60 years of age who achieved at least a PR to induction therapy, not eligible for stem cell transplant. Then also they are talking whether to give rituximab or any other previous form of therapy, which was interferon alpha. I know this is not the topic of discussion, but compared with interferon alpha, rituximab improved overall survival at 4 years, which was 87% versus 63%. So I've shown no rituximab and rituximab showing PFS, EFS, OS advantage, and rituximab as compared to any other drug is also better. So the risk of progression or death HR ratio was 0.55. So this is what I know in hematology, oncology, we don't follow NCCN as compared to solid. But if we have to give my view on NCCN, which is the latest version 2021, so it clearly said if the disease is aggressive, upfront, as we do in a myeloma protocol, the candidate is fit for autologous stem cell transplant. Give therapy aggressive, first CR, take it for a transplant, then give it as a maintenance therapy. So consolidate with transplant, then give it maintenance therapy. If you have a PR, consider this patient for an aggressive, slightly aggressive, add cytarabine, then take it for transplant. And if patient is not a candidate for transplant, in a CR, we should give maintenance rituximab. In a PR, consider second line and then consider maintenance rituximab. So NCCN guidelines are very clear on induction therapy, how in an aggressive and less aggressive, very clear on consolidation therapy after aggressive, which is a autologous stem cell rescue, very clear on the timing and duration of maintenance therapy, which is 3 years, category 1 recommendation of maintenance rituximab. And they also talk about maintenance rituximab after less aggressive therapy, although not clear after bendamustine rituximab. So I think we should prognosticate and plan our maintenance cell lymphoma or mantle cell lymphoma patient very rightly upfront. Choose right induction therapy as per age, performance status, MIPI index. Consolidate with autologous stem cell transplant at the best response, which is CR, rather than multiple lines of therapy and then taking for autologous. There are papers which I have discussed. Maintenance therapy with rituximab, even without transplant. There are paper in older patients with transplant, the LYSA study. So it has been proven beyond doubt that maintenance rituximab post autologous stem cell transplant in a patient who are fit to take this therapy after induction gives you the best OS, PFS, and event-free survival. So I think I rest my case with this evidence and looking forward to hear out Dr. Biswas for this. Thank you so much.
Thank you, Dr. Ankur, for a very forceful presentation. You convinced everybody. Now let's see how Ghanshyam opposes you. Go ahead, Ghanshyam.
Thank you, Agarwal sir. Thank you, Image, and thank you, Dr. Reddy's. So Ankur is a good friend. So he's traveling back home from hospital. So I don't want to hold him. So there are two important. So always an upfront. So we are talking about an consolidation stem cell transplant and a rituximab. So I am against the motion. So mantle cell is a disease. So we have heard Dr. Rina's follicular lymphoma, then Dr. Gaurav's DLBCL. So this is a totally a different story. So this is a rare, but there, and you will agree that this is a indifferent disease altogether. So coming to types of mantle cell, so the clinically aggressive variant are blastoid and pleomorphic, and there can be an aberrant phenotype. So what are the other variants? There can be a SLL type or an marginal zonal type. So coming to indolent or an early mantle cell lymphoma, which is not less, so around 15%. So according to one of those literature, and the classical mantle cell is 80%, and there can be a category from a classical to a blastoid of a transform, so which can constitute 5%. So coming to this busy slide, so we see that there are two importance which Dr. Ankur also highlighted. So besides cyclin D1, so what is important is looking at the SOX11. So if they are positive and unmutated IGHB, so we are talking about in the disease in the lymph node and extranodal. So this is a classical mantle cell lymphoma. So in presence of Notch1 or Notch2 or a mutated TP53, so they can go into a blastoid or a pleomorphic mantle cell in the presence of a genomic instability and a high proliferation. So in the other group where cyclin D1, so 11-14 translocation is there, but SOX11 is negative. So there is a hypermutated IGV, and so this is a disease not in the lymph node or the extranodal. So it is in the blood, bone marrow, and the spleen. And these are basically a genomic stability and a low proliferation as compared to the classical MCL with the genomic instability and high proliferation. But the notorious TP53 can convert into a pleomorphic mantle cell, not a blastoid here. So and then a genomic instability and a high proliferation can be seen. So this is classical versus the leukemic non-nodal. So that brings us that one size doesn't fit all. So we are looking at a limited edition of a mantle cell that is an indolent type. So how do you difference between a smoldering and a classical mantle cell lymphoma? So it is like defining a multiple myeloma or smoldering or a prototype of a multiple myeloma. So there can be a clinical features difference. So there can be ACV difference once you do a PET scan. And so the cytology is usually a pleomorphic or a non-blastoid as compared to in classical, so where you can get a blastic. So there are immunophenotype differences, but the difference mainly lies in the genetics. So we talk about TP53, we talk about Notch1 and 2, CMYC, cyclin D1, mRNA, so which are definitely highly expressed in the classical MCL. So coming to prognosis, which Dr. Ankur has already shown, so we rely on mantle cell lymphoma international prognostic index. So it can range from 0 to 12. So with age, ECOG performance status, LDH and WBC. So with a low risk, so you can have a 5-year survival of 60%. And with the highest risk, so you can have a 20% 5-year survival. So another important is a Ki-67. So if it is less than 10, so you can have a beautiful survival when it is more than 40 or more than 30. So you can see, so which is a biologic MIPI, so the survival is definitely compromised. And you are looking at this Ki-67 in nodal and not in, and the extranodal tissue, but not in the bone marrow. So this slide can show you if you have a both low MIP and low Ki, so the overall survival can be more than, in the 5 years, can be more than 80%. And at least if one is lower and another, the MIP is intermediate, so you can still have a OS at 5 years of 70%. If you pick up any of these highs, so either a high MIP or a high Ki-67, then the survival goes down to 40, and with both high, so you have a less than 20% of OS. So these are certain prognostic marker with the negative values on the left-hand side, performance status, CNS involvement, transform type, blastoid, high Ki-67, complex karyotype, and on the right-hand side, you can have a Notch1 or Notch2 or a CCNB1. So the management algorithm can be number one. So as Dr. Ankur said, so it can be induction. So normally, so after that you follow up with the stem cell transplant, then a rituximab maintenance for a 2 monthly, and do an MRD, which is not a fashion yet. Then you can augment your treatment. The other can be on the A, so newly diagnosed MCL, so where you give an induction treatment. So it can be hyper-CVET or it can be R-CHOP, alternating with the RDAP, and do an MRD. So if his MRD is negative, then probably you go for a maintenance. And if our MRD is positive, then probably you are a candidate for a stem cell transplant. So this is from the ESMO. You can see a young fit patients. So they can go for all those what Dr. Ankur has said. But elderly patients more than 65 in an Indian setting, so most of these will be a diabetic or any other comorbidity, including a cardiac issues. So they may not be a candidate for a stem cell transplant. And so we cannot talk about the rituximab maintenance or stem cell transplant in a compromised patients. So where the intent of treatment is absolutely a prolonging of life. So you choose a better regimen without much of toxicity. So a newly diagnosed mantle cell from the American Society of Hematology on the left-hand side, if it is a leukemic non-nodal type, a non-bulky disease, lower Ki67, non-blasted, good performance status, no B symptoms for a normal LDH. So you are going to observe, and the aggressive disease can be discussed in terms of age, in terms of comorbidities which are controlled or not. So are a fit patient. So if a fit patient, they are eligible for what Dr. Ankur has said. But those with the comorbidities, elderly patients, frail, so they are not the candidate for induction followed by considered maintenance. So this is from the Asian Lymphoma Society study group. So they also does the same thing. So the SOX11 becomes so important here. So if they are negative and asymptomatic patients, so wait and watch. But for asymptomatic patients, you go the way. So we are treating aggressive lymphomas. So this is the NCCN. So probably from stage 2 on bulky onwards, what Ankur showed. So this is a stage 1 or a contiguous stage 2 non-bulky. So they are not a candidate for an aggressive therapy. So they are candidate for either a local treatment with the radiations or a chemoimmunotherapy. And there can be a group of patients where you can still observe them. And this is what Dr. Ankur showed. So aggressive go the way, the indolent. So these patients, either they can be treated or they can be observed. So this slide shows these NCCN. So what are you going to do with those indolent or SOX11 negative or IGHB mutated? So there are patient populations where still can be observed on a regular follow-up unless and until they have symptoms or they are having a TP53 mutated and they are converted into a pleomorphic or a blastoid. So we have Dr. Ankur has shown the aggressive therapies, but still there are patients in our clinical practice, and we see these are patients, elderly patients, they cannot go for an aggressive therapy. So they usually go for something like a bendamustine and rituximab and a consolation. So we have seen in the COVID times, so many for last 2 years, so the stem cell rescue so was a difficult treatment for most of the patients to go to the major centers. So maintenance treatment after high dose therapy, and so across all subsets, we have seen that patients who have received a BR, so they doesn't benefit with the maintenance therapy. So these are the treatment of mantle cells. So from no currently available treatment option is curative at this moment. So we are looking at improved survival. So options of chemotherapy, radiations, immunotherapy, immunotherapy, stem cell transplant, even proteasome inhibitors, and there are many other biological agents. So on the left-hand side, if you are using a R-bendamustine and an R-CHOP, you can see we can still have an overall response rate of 90% with a CRS rate in a R-bendamustine, which is not so aggressive, but even a CR rate of 50% with a PFS in the still trial of 70% as compared to R-CHOP, which is 31%. This was statistically so significant. So maintenance rituximab, as we discussed, so there is no survival benefit of rituximab, especially in a bendamustine rituximab, those who have received. But for R-CHOP, so definitely, but if you can see those patients who have received a stem cell transplant, so 4-year OS was 89 versus 80. So the p-value was 0.04 only. So these are some of the Indian publications. So one of our colleague, Dr. Raki. So we see that there are patient populations which are a little bit younger. You can see 38, 42 years. These are the patients who has been published. We can see from our own alma mater, even with Dr. Harimanan and Dr. Gujral. And there is another paper from so where the median age was 58, and there were patients who have quite a number of patients were SOX11 negative. So we are talking about a mantle cell, we are talking about an indolent mantle cell, we are talking about a SOX11 negative. So like rare people, rare disease, so the rare people in real life who will show up at the right time, help you through the hard times and stay into your best times. So those are the keepers. So ladies and gentlemen, so we are looking at the beautiful mobile, but we have forgot that this gentleman having a costly watch also. So in the war of looking at what is more prominent, so at times we miss, so what is not more evident. So mantle cell lymphoma is a gentle looking aggressive lymphoma. So in summary, many new therapeutic options, but many ongoing questions. So in the clinical summary, high response rate to chemotherapy, but you'll agree that is a short duration, better response duration, but not curable even with CBAD and even with the stem cell transplant. So optimal treatment regimens remains unclear. So promising recent advances in biology and treatment is there. So the goals and selection of treatment depends on is MCL aggressive since it has a short median survival. Is MCL indolent since not curable with CHOP-like regimen. So to conclude, so not every MCL are the same. We need to select out innocent cohort amongst this. So definitely, yes, young, fit, and a higher stage or a higher MIPI are the only candidates, and that too in our setting affordability. So are one of the candidates for aggressive treatment, which constitutes stem cell transplant and rituximab. So I rest that MCL not always needs not an upfront stem cell transplant or rituximab maintenance. So we have seen in the hard times, COVID pandemic, challenges of ASCT, and the most notorious rituximab as a drug in any setting. So that was really a challenge. So the reality check is that, so the client's expectations are different, and but the clients, we have to look at the client's budget too. So at times we get happy with that. So thank you, ladies and gentlemen, for this opportunity. Over to you, MD sir. Thank you so much.
Thank you, Dr. Ghanshyam. Once again, a convincing talk. Any rebuttal from Dr. Ankur?
Yes, sir, certainly. So I think Dr. Ghanshyam was saying whatever I was saying, but I just want to say that in a patient who is young, who has got, who's fit enough, and who has got everything for this rare disease, so there is an OS advantage, there is a PFS advantage to both of these. Dr. Ghanshyam is saying that there is no advantage. I understand that post BR, post bendamustine rituximab, we do not have a publication or a literature suggesting an evidence, but I don't find the signs that post RCHOP you should give rituximab maintenance, and post BR you should not give rituximab maintenance, as we see in our follicular lymphoma. So Dr. Ghanshyam has helped me in this debate. There's no more debate, looks like. So fit young patient, less than 60, who have organ preservation, who is fit for autologous stem cell transplant. Is Dr. Ghanshyam going to say that no transplant and no maintenance? He has emphasized that no transplant and no maintenance for an elderly population where we might not be benefited with this subset. But all patients who are fit and young should get autologous stem cell transplant. The guidelines say so, the NCCN says so, and even the ESMO says so. So I don't find any reason where it should not be done in a fit patient. Thank you.
Thank you, Dr. Anku. Thanks, Dr. Ghanshyam. Both of you have a wonderful dinner on behalf of DRL.
Thank you, sir. Thank you.
We go to the fourth part of this wonderful webinar, which is now slowly coming to an end. So this is 5 days long webinar conceived by Dr. Reddy's, managed by Mumbai Hematology Group, year in review, mainly discussing what was new in last 9 months of the current year. We have this great molecule, rituximab. We have been discussing this all through for last 20 years, and from the house of DRL, you have Reditux, useful for all CD20 positive lymphomas, whatever type they may be. We have 3 lovely papers to be now discussed, and each one of them has 10 minutes, and we have 3 great speakers with us. First is optimizing use of PET scan in non-Hodgkin lymphoma by Dr. Neeraj. Siddharthan, who is clinical professor and HOD, Department of Clinical Hematology at Amrita Institute of Medical Sciences, Kochi. This will be followed by an exciting talk on CAR-T therapy in lymphoma by Dr. Satya Dattatray Palanki, Chief of Medical Oncology at Renova Soumya Cancer Center, Hyderabad. And lastly, of course, we move away from NHL, get into Hodgkin lymphoma and how we treat a newly diagnosed Hodgkin lymphoma advanced stage. Data in last 9 months. Dr. Joseph John, Professor, Department of Clinical Hematology, Hemato-Oncology and Transplantation at CMC, Ludhiana. So let's begin with Dr. Neeraj first.
Thank you, sir. Good evening. Good evening, sir, and thank you for this opportunity. Let me share my screen, please. Okay. All right. So, so the topic I'm supposed to review a paper published in 2021, which deals with optimizing the use of PET scans in non-Hodgkin's lymphoma. As we know, we have kind of optimized the use of PET-CT in Hodgkin's lymphoma, and in non-Hodgkin's lymphoma, still, there's a lot of debate on how to use this. So I thought I'll choose this paper and discuss this paper, which is published in Blood in February. And this is basically from Sierra Freeman and group from the British Columbia Center in Vancouver in Canada. And they have looked at long-term results of PET-guided radiation therapy in patients with advanced stage diffuse large B-cell lymphoma treated with rituximab CHOP. So as a background, I think we all know that in diffuse large B-cell lymphoma, we have 60 to 70% remission rates with R-CHOP. And in practice, most of us treat advanced stage disease with 6 cycles of R-CHOP, sometimes going up to 8 cycles. Now, in addition to the R-CHOP, now there is also the option of radiation therapy, and there's some confusion right now as to how we use the radiation therapy, and that is the area where this paper deals with. So some of us offer radiation therapy to patients who present with bulky disease. Sometimes we offer radiation therapy to patients who have residual mass after completion of chemoimmunotherapy, whether they didn't have a bulky disease at the beginning also. Sometimes we seek consultation from our radiation oncology colleagues where if we have extranodal sites involved. So in this setting, the practices are widely variable. Even within an institution, you would find a variation in practice here. So in this context, if you look at the PET-CT in DLBCL, how are we using it right now? I think we all realize that it is very sensitive. In fact, PET-CT is very much used for, selecting the site of biopsy. And it is very commonly right now used as a staging tool. Now, we also tend to do the end of treatment PET-CT for assessing remission. So talking about the end of treatment or EOT PET-CT, there are some data from different studies looking at the progression-free survival. So in general, the progression-free survival of patients who achieve a complete metabolic response at the end of treatment is somewhere above 70 and reaching about 86%, versus a very variable 24 to 64% for those who have a persistent PET-positive disease. So that's a very variable survival or progression-free survival for a PET positivity. So it's an area of debate on how best to approach a PET positive disease at the end of treatment. So, and unfortunately, we don't have any randomized controlled trials on the role of RT based on end of treatment PET-CT. Now, in this background, this paper is based on the retrospective data from British Columbia in Vancouver, and then the data is taken since 2005, and basically they have looked at advanced stage newly diagnosed DLBCL cohort. So the patients have received 6 cycles of R-CHOP, and then they have undergone a end of treatment PET-CT. And in general, the uniformity of practice that they had was that if you have a PET-CT negative, they would observe the patient irrespective of what was happening at the staging PET-CT. If you have a PET-CT negative, then they're just observed. Whereas if you have a PET-CT positive, then consolidative radiation was given. And this is for a PET positivity which didn't require kind of a biopsy. It's not like a disease progression, but there's some PET-CT positivity, and those were given consolidative RT in the absence of overt disease progression, and whenever feasible. Sometimes some areas, it is not feasible to give. So the inclusion criteria, again, the setting of the study was patients who were diagnosed with between 2005 and 2017, adults and with DLBCL. And the advanced stage of disease was defined as stage 3 or stage 4. And obviously, and then stage 1 or 2 with B symptoms, or stage 1 or 2 with bulky disease. And the patients were all treated with a curative intent with R-CHOP were included. And the other inclusion criteria was that they should have had an end of treatment PET-CT performed. Now, the end of treatment PET-CT was performed 4 to 6 weeks after completion of chemoimmunotherapy. And PET-CTs were usually reported initially, as we all know, initially the PET-CTs were reported according to the International Harmonization Project till 2014. But from 2015, according to PET-CTs were reported according to DeVilliers score, and anything less than 4, that is 1, 2, and 3, were considered as negative PET-CT. The consolidative RT was between 30 to 40 grays in 15 to 20 fractions. So this was the patient characteristics. As you can see that the total number of patients was 723. And PET-CT negative was 517 at the end of treatment, and PET-CT positive at the end of treatment was 206. Now, most of the characteristics of age, sex, ECOG performance score, staging, marrow involvement, extranodal sites, skeletal involvement, craniofacial involvement, etc., and IPS score was uniform. I mean, it's comparable between the two groups, except a few things. You had more B symptoms, more elevated LDH, more bulky disease, and less hemoglobin in those with the end of treatment PET positive disease. Now, they have then looked at the time to progression as well as overall survival in both the PET positive and PET negative end of treatment. So in this figure A, you can see here, it looks at the time to progression, and you can see that the PET positive had a worse outcome compared to end of treatment PET negative cohort. If you look at the overall survival also, there is a very clear demarcation between those who were PET positive at the end of treatment versus the PET negative. And as I mentioned earlier, in the PET positive group, many patients who were able to receive RT received it. And when they looked at that cohort, though in the PET positive, those who received RT had comparable survival to that of PET negative group, both time to progression as well as overall survival. Now, also, another interesting thing was, initially, if there was a bulky disease, we all would have expected a worse outcome. It's a higher risk thing. But if the bulky disease patient had a PET negativity, around 140 of them, if they had a PET negativity, they had equivalent survival as a PET as a non-bulky disease. So similarly, patients with or without skeletal involvement in the beginning had similar outcome if they became end of treatment PET negativity. So all those initial high-risk features were nullified if they became PET negative. Now they did univariate and multivariate analysis on PET negative group and to see what were the risk factors for time to progression. And in the multivariate analysis, they found that the B symptoms as well as the marrow involvement in the beginning were risk factors for time to progression. Now, as I mentioned earlier, then some of these PET CTs were reported according to harmonization project before. And such PET scans were reclassified by DBLA criteria in retrospective analysis. And even then, even when they were reclassified by the DBLA criteria, which is more objective, you can see that there is this is a PET positive who didn't receive RT. This is a survival of PET positive who received RT, and this is a PET negative group. So there's a demarcation that those who received RT, the survival didn't reach up to that of the PET negative, but it is still far better than the PET positive group who didn't receive the RT. So those were the results. And if you look into other literature, there similar results have been reported in sub-analysis of the Goya trial with a landmark analysis from end of treatment reporting that about PFS of 86% for those who became PET negative. And for the now elderly trial of optimal 60 trial with patients with DLBCL, also a similar results were obtained. So, but in this papers, there are still certain points which are not clear. I think one is that, even in the patients who were PET negative, a small proportion of the PET negative patients, about 15% of them still relapsed. So PET negativity doesn't guarantee that there will not be any relapse. So similarly, there was also another finding, observation that a proportion of the PET positive patient at the end of treatment who did not receive RT did not relapse either. So that also was difficult to explain. The limitations of this study was that it was a retrospective study. It was not a randomized study. And the staging PET CT was not done for everyone. So maybe some of the advanced stage disease were classified as a early stage disease because initially CT may downstage, as we all know. And during the initial period, end of treatment PET CT was done only for the patients who had residual disease on end of treatment CET. So those were some of the limitations. But I found that this paper still had a lot of strengths. One was that this was having a very long follow-up, 12, 13 years, very good numbers of about 700, very mature data, especially the real world data. And very importantly, the PET CT was done and reported as a single sender. So that nullifies a lot of bias there. And it was a fairly uniform treatment protocol in a real world setting, which is also hard to match in a real world setting. So those are the strengths of this paper. And this is my final slide. This is in summary of this paper, where you can see that if this were a randomized trial, and this is how it would look like, you have the patients who have received R-CHOP, and then you have an end of treatment PET CT. And if you have an end of treatment PET CT, they were observed. And if you have end of treatment PET CT positive, RT was given if feasible. And patients with advanced DLBCL, those who have an end of treatment PET CT have an excellent prognosis without RT, irrespective of whether they had a bulky disease or skeletal involvement or extranodal involvement in the beginning. And non-progressing patients with positive end of treatment PET CT given RT appear to have better than expected outcomes, and that providing rationale for this approach. So in the absence of other randomized controlled trials, this paper has good insights into modifying our practice. With that, I conclude. Thank you very much.
Thank you, Neeraj, for picking up a very important paper and discussing it at length. Enjoyed listening to it and learned a lot. We have a couple of minutes if some faculty has any question. From audience, there is no question put in the question box. If somebody over here has any question, please go ahead. Okay, then Neeraj, you have done a perfect job. We move on to the second lecture, and that's by Dr. Dattatreya Satya Palanki, CAR T therapy in lymphomas.
Thank you so much, sir. Kalpesh, thank you so much for sharing and controlling the slides. So I chose this next slide, please. I chose this review article, which was published 6 months back on 6th of April 2021 by Rosalie Sterner and from the Mayo Clinic in Rochester in USA, to let us know about the 5 important limitations of CAR T-cell therapy, especially in regard to lymphoid malignancies or solid tumors when compared to hematological malignancies, and how we can have some potential therapy options to circumvent these 5 current limitations of CAR T-cell therapy. Next slide. Let me briefly touch upon the CAR structure. Next slide, please. Which, as you know, as you can see, the 2 greens there, that is the single chain variable region of the antibody, which provides target specificity. And then there is a hinge region, and then a transmembrane region, and then the T-cell activation domain. So this is how the CAR looks like, the chimeric antigen receptor. Next slide. We actually had the first generation CARs where you directly had only the T-cell activation domain. And these first generation CARs were not able to elicit responses because they did not have the mandatory co-stimulatory region. And so came the second generation CARs, next slide, where you find in the red the co-stimulatory region, and that's able to activate the T cells and then the further downstream signals. So you could have 2 types of co-stimulatory domains. One is CD28, next slide, and the second is 4-1BB co-stimulatory domains. So these were second generation CARs where you had a co-stimulatory domain. And now we'll be having the third generation CARs, next slide, where you have 2 co-stimulatory domains, both CD28 and 4-1BB. So this was trying to give an example of how first generation CARs to second generation and third generation has evolved. In the first generation CARs, you did not have the co-stimulatory domains at all. In the second generation CARs, you had 1 domain. In the third generation, you have 2 domains. Next slide. So with that, I'll come to 5 important take-home messages of the potential limitations. And the first is, when we give CAR T cells, initially you might have high response rates, as you see in some of the hematological cancers, but then a significant number of these patients develop tumor resistance. And that's because when resistance happens, you find that there is loss of the target antigen expression. Now, the malignant cells therefore lose the antigens to which the CAR T cells are directed, and this is therefore labeled as antigen escape. And that, next slide, is a common disease resistance mechanism. For example, when you're targeting CD19 in ALL, in 30 to 70% of them, you would found that the CD19 would have become lost or downregulated. In multiple myeloma, loss of BCMA expression happens in these patients when you find that the CAR T cells are not working. Next slide. So CAR T cells working on a cancer related to the target antigen. When resistance happens, next slide, you now find that the cancer cell does not have the target antigen. And that's labeled as, next slide, antigen escape, the most important mechanism of or limitation of CAR T cell therapy. So how do you potentially approach this limitation? Next slide. So you can have dual targeting CAR T cells, for example, CD19 and CD22 for ALL, adult ALL patients, and it showed promising results. For multiple myeloma, you have your target CD19 and BCMA, and again, it proved efficacious with favorable safety profiles. So that's one way to target this limitation. Next slide. So section 2 of my talk, next slide. Lymphomas or solid tumor antigens are often expressed on normal tissues also at varying levels. And when the CAR T cells might therefore target these normal tissues, and that would lead to activity on the target, but on normal cells and therefore off tumor, and that would lead to the adverse. So this is called as on target off tumor toxicity. Next slide. So you have CAR T cells. The cancer cell has the target antigen, but the normal cell also has the target antigen. That leads to, next slide, the on-target off-tumor toxicities or adverse events. So how do you tackle this limitation of CAR T-cell therapies? Next slide. So even in these antigens, so these tumor antigens undergo post-translational modifications. For example, you could have truncated O glycans or CLIization of these glycans. And these are the 4 major CAR T-cell targets we have seen: TAC72, B7H3, MUC1, or MUC16. So first generation CAR T cells in colon cancer did not produce responses, but second generation tags under CAR T cells, which are looking at these tumor restricted modifications, are being currently investigated. So you're trying to look at the tumor antigens and trying to exploit the post-translational modification, which is not seen in normal cells. Next slide. So we spoke about antigen escape. We also spoke about on-target off-tumor toxicity. We'll now come to next slide. How in lymphomas, because in liquid tumors, the CAR T cells reach the bone marrow or the bloodstream. In lymphomas or solid tumors, it becomes slightly tough for the CAR T cells to traffic to the solid tumors or infiltrate the solid tumors. Or one barrier is the tumor stroma itself, and that will penetrate, that will limit the penetration of the CAR T cells. Next slide. And so you have the CAR T cells which are not able to reach the tumor area or the lymphomatous neoplastic area. So that is one more potential limitation of in solid tumors or lymphomas. Next slide. CAR T cell trafficking and infiltration becomes an impediment when it comes to solid tumors or lymphoid neoplasms. So what can we do about that? Can we give the drug, can we give the CAR T cells locally? Now that has worked in, for example, brain metastasis from breast cancer or GBM patients by giving the CAR T cells intraventricularly inside the CNS ventricles, or for patients of mesotheliomas, giving the CAR T cells intrapleurally. So this can be applied only for those patients who are having an oligometastatic area of involvement, and that too preferably in cavities. Next slide. CAR T cells also can be therefore used for a broader arena when you can also make them express the chemokine receptors, because tumors derive their chemokines, and therefore you could have CAR T cells with chemokine receptors so that they can reach the area of interest to that tumors inhabiting the tumor chemokines. For example, you modify the T cells to express CXCR2 or CXCR2 that will enhance trafficking and significantly improve the anti-lymphoma efficacy of CAR T cells. Lastly, the CAR T cells also have to navigate the tumor stroma. And one important part of the matrix is something called as heparin sulfate proteoglycan. So you could now have CAR T cells which are engineered so that they express an enzyme called as heparinase, which will then lyse the heparin and therefore leach the solid tumor cells. Similarly, you also have to navigate or circumvent the fibroblast, and for that you could use the fibroblast activation protein targeting CAR T cells. So they can reduce the tumor fibroblasts in animal models, and that will make them reach the lymphoma cells or the tumor cells. So that was the third limitation, which possibly can be targeted by using these methodologies. Coming to section 4 of my talk, next slide. We look at the abbreviations there because you could have various immunosuppressive cells in the lymphoma microenvironment. Right? For example, MDSCs or myeloid-derived suppressor cells, TAMs or macrophages, which are with the tumor, or Tregs, which are regulatory T cells. Now, these infiltrates in the tumor area or in the tumor microenvironment, which basically produce chemokines, cytokines, and growth factors, which are inhibiting the CAR T cells from making their activity, from making their cytotoxic activity. In addition, PD1 and CTLA4 also, as immune checkpoints, decrease the anti-tumor immunity. One of the main reasons of no response or a weak response to CAR T cell therapy is poor T cell expansion. And even if they do expand, short-term T cell persistence. So what can we do about that? Next slide. We're now looking at, therefore, the Tregs, the MDSCs, and the fibroblasts. And this, therefore, is, next slide, the immunosuppressive microenvironment that doesn't make the CAR T cells work as they should in lymphomas or solid tumors. You use combination immunotherapy. Next slide. So use CAR T cells and checkpoint blockades, and that has ensured the T cell persistence is sustained and functionality is maintained. For example, in CAR T cell therapy of 14 children having heavily treated B cell ALL, CD19 CAR T cell combined with PD1 blockade produced improved persistence of CAR T cells and better outcomes in one study by Pennsylvania. Lastly, next slide, last part of my talk. What about, next slide, the CAR T cell associated side effects? Now, this has been, CAR T cells are a revolutionary cancer treatment tool, but high rates of toxicities have prevented CAR T cells from first-line treatment. Critical factors which determine the side effects of CAR T cells are the design of the CAR, the specific target, and of course, the tumor type. Next slide. And so let's talk briefly about, next slide, CAR T cell associated toxicities. As you can see, the cancer cell is being tackled at the same time, the myeloid cells and other cells also, with the interaction with the CAR T cells, result in various CAR T cell toxicities. 3 of them are important. Next slide. For example, in almost 50% of patients of ALL or lymphoblastic lymphomas, you find production of cytokines and massive in vivo T cell expansion. And that immune cell cross-activation leads to the following side effects. Number 1, next slide, is CRS or cytokine release syndrome. Number 2 is HLH and MAS or macrophage activation syndrome, which means in addition to CRS, you also have altered LFT, altered RFT, high serum ferritin, hemophagocytosis, pulmonary edema, and absence of NK cell activity. The third is what is called as ICANS, immune cell associated neurotoxicity syndrome, which means elevated fluid cytokine levels and blood-brain barrier disruption. Now, these 3 side effects, CRS, MAS, and ICANS, to date, now next slide, we don't have any approved treatment which can prevent the above toxicities. Therefore, to bring you down side effects, we can engineer the CAR T cells by altering the CAR structure, by making them less immunogenic against the host, but to the lymphoma more toxic, to modify the CAR to induce T cells and reduce the neurological toxicity, and also to have CAR off switches. Next slide. So therefore, to conclude my talk, we have 5 mechanisms. 1, antigen escape. 2, on-target off-tumor toxicity. 3, CAR T cell trafficking and infiltration. 4, the microbe, the environment is immunosuppressive. And lastly, how to tackle the CAR T cell side effects. So that's what this review paper was chosen by me, so that the limitations of the CAR T therapy in lymphomas or solid tumors. Thank you so much, sir.
Fantastic, Satya. Great talk. I had never understood CAR T till today. Thank you. Any questions? We have ample time if somebody wants to ask a question. All Right, so we come to the last talk of this marathon webinar, and none other than, of course, Professor Joseph John, an entirely different disease, Hodgkin. You can go ahead, Dr. Joseph.
Thank you, sir, for a kind invitation. And I know everybody is tired and hungry, so I'll try and do justice in the next 10 minutes on the topic which I have been given. On reviewing this advanced Hodgkin's disease, I too learned much, and and the staging wise, if you have to recollect this, it is advanced stage is when 2B or more. And the advanced stage is class stage 3 or 4 is called the advanced stage, and that is risk stratified based on these 7 criteria, and that's a distribution of the advanced stage patient distribution. So if you look at it from the advanced stage, high risk 4 and above are about 20%. 80% of them have less than 3 risk factors. When we look at the freedom from progression or overall survival at the end of 5 years, freedom from progression at 77 months, it is about 60 to 80%. And overall survival is somewhere between 60 to 98%, which means that even in an advanced stage patient, there is a 60 to 80% chance of progression-free survival, and overall survival of about 70 to 80%, 70 to 90%, which means to say that it is not too bad, even though it is an advanced stage disease. We have 3 choices to choose from: ABVD, bendamustine vedotin, and EBCOP. I did a search on advanced stage and Hodgkin's disease from the PubMed, and we could find about 544 hits. And in the last 2 years, it is only about 20. So I chose about 5 publications. One is role of RT in bulky disease, the classical prognostic factors versus in the PET guided therapy. Is that holding true? Hodgkin's lymphoma post-autologous transplantation, consolidation, and cost effectiveness of bendamustine, and ABBD versus BCOP. And that's the most important paper I would like to discuss today. In the radiotherapy point of view, what it showed is that there is no role of RT, even though you have bulky disease. So the verdict is that in the intention to treat analysis, the event-free survival at 2 years is 87% if you gave RT, or 85% if you did not give RT. The p-value is not significant, and therefore RT was falling out of favor. Even in a per protocol analysis, it was only 89 versus 84. P-value was still not significant. With regard to progression-free survival, also there is no difference. That was overall freedom from progression or progression-free survival also did not show any advantage in with response to a patient with complete metabolic response. So if there is a complete metabolic response, even though there is a bulky disease and diagnosis in advanced stage, the RT did not show much of a difference. The 7 criteria for prognostic factors did not hold its water when we looked at the PET-guided therapy. So I'll come to some of the treatment and therapy decision-wise. The debate is between the 3 major components. 1, RT should be given or not. 2, what to be given upfront in an advanced stage. And should we go for PET-guided therapy or a standard ABV? These are the 3 clinical equipoises we had, so to speak, in the last few years. So it is elegantly showing that, and it is to understand that the Kaplan-Meier is converted to a tabular form, and they are comparing all the 7 risk factors in a PET negative and a PET positive, and showing that the 7 criteria did not hold good. If we were to go for PET positive or negative therapy, then you are taking a risk factor or a decision-making point much further away from the factors at diagnosis. Same happened to absolute monocytic count, neutrophil lymphocytic ratio, and lymphocytic monocyte ratio. This is showing that after autologous transplantation in advanced disease, whether in terms of monotherapy with bendamustine had its advantage, but only 3 patients they had, so it was not a kind of a randomized study. It's only case reports. This was interesting, I thought, because we're speaking so much of bringing in brentuximab upfront in advanced stage. So even in Canada, I would say, the cost effectiveness was shown that the study showed that it was not cost effective to use bendamustine upfront in Hodgkin's lymphoma. I wouldn't go into details of that. We can do that at some point later. So this is the detailed, debates which we were thinking. And to put the background on ABVD, we understand that 80% of the patients of ABVD gets complete response, and 25% of them would progress. 50% of them would respond to an autologous transplant, and the overall survival at 4, 7, and 10 is 90, 75, and 55%, which means that if you gave ABVD and say 20% of them progressed, you could still salvage and give them a long-term survival with autologous transplant. So only you're losing out on the 10%. However, ABVD can cause bleomycin-induced toxicity, and that was one of the points which are pipped against the ABVD with the BCOP and the AVD groups. It is reversible. Mortality is about 4.2%. The advantage of ABVD is that the risk of permanent infertility is only about 5 to 10%. And even if you had an azoospermia, almost all of them were recovering to normal as compared to BCOP 80 to 100%, 90 to 100% infertility. So this was one elegant study, I thought, not in the last 9 months, but last year, ABVD versus BCOP in escalated. It is a retrospective study from 7 centers in Europe, showing that absolutely no difference at the end of 8 years. It is 80%, 75%. For that 5% advantage, do I want to subject the patient to an intensive and an expensive therapy is the question. With regard to overall survival, again, it is 90%, 87%. That's a 3% advantage at the end of 8 years. When it came to severe hematological toxicities, the BCOP was way ahead of ABVD. When it comes to secondary malignancies, BCOP scored higher than ABVD. So it is a clear winner there in terms of ABVD with regard to long-term toxicity, even though BCOP offered a marginal advantage in the PFS and OS, 2%, 3% and 5%. When it came to response adaptive therapy, that's the next interim decision-making process which we do. That after 2 cycles, do a PET. If there is disease process, continue with BCOP or continue with ABVD into 4. That is subject to various other situations in terms of the sensitivity of the PET and where are you comparing with, what is the dual score we have used, etc. So this had an advantage of a de-escalation or an escalation therapy. Various groups came up with. The rattle group is one which we generally look at too, but Germans have a different way of looking at it. The Americans have a different way of looking at it. And the Indians, of course, non-PET adapted ABVD into 6 straight up with interim X-ray and ultrasound for limited resources. So that's various trials on the PET adapted therapy. The Rathel score based upon the AVD and ABVD, that is, you can de-escalate if there is a decision. However, this decision has been only with one study, and many people are looking at the patient and the affordability and the ability to take up the ABVD continuous, even at the end of 2 cycles, if the PET is negative, to decide whether to give the advantage of ABVD versus AVD. That's a personal call which still the clinicians are making. It is showing difference, not much of difference, even with an escalated BCOP or a de-escalation. So even if you had continued with ABVD or AVD, it did not show much of a difference. But here the trade-off is between Do I want to risk him with the bleomycin toxicity? On the other hand, if there is PET positivity, do I want to risk with high dose BCOP is the next question in hand because of the cost involved and the toxicity involved, or give the entire ABVD, then decide of a salvage therapy followed by an autologous transplant would be equal cost. So since the paper was how I should treat, I went through this entire cycle of discussion. And when we look at it, what should be our approach, we need to look at the facts, values, preferences, convenience, and the cost. Why would I say that? Because on paper, BCOP may be better off. ABVD, BV, bendamustine ABD had shown a 5% advantage over ABVD alone, and lesser toxicity there with the BV, but neutropenia and the hematological toxicities were more with the BV group. That's a 2018 paper from NEGM. That's why I did not put it in. That is when the first time bendamustine was being proposed for the stage 3, stage 4, and came the EBCOP and the escalated BCOP, that is, and the comparison arm came in very late. Otherwise, BCOP was all the way being proposed in various forums. We need to look at the values, the preferences. Why would I say that? Because the cost becomes one of the major issues. The sterility and the infertility becomes one of the major constraints when we decide on a treatment. ABVD has time tested and proven. And therefore, I would prefer to say that ABVD is how I should treat with regard to advanced stage, even in an advanced stage Hodgkin. That's a cost comparison just for our understanding. If I have to distill it down and ask the question, do I want to give EBCOP or a BV for a 1.6 to 5% advantage in an 8-year progression-free survival or an 8-year OS at a 24 to 40 times the cost? Understanding that even if I had given ABVD and they had relapsed, that's a 20% chance of relapse, I could salvage them with a salvage therapy with either GDP or any of the salvage therapies, and take them for an autologous transplant with a cost of lesser than what we offer in BV-ABD. Thank you so much.
Thank you, Professor. Great job done. Once again, a subject so simplified, and each aspect of what you covered was so important. Everybody must have understood, everybody must have learned, and it will change their practice. Questions? We have time. If there are any questions? Crystal clear, so simple. Grateful to you. So on my behalf and on behalf of MHG, we come to the end of this 5 days marathon, and I just hand it over to DRL. Abhishek is here to conclude.
No, I think, sir, as you rightly said, it was a true marathon, and I believe a feast in terms of the scientific discussion for everyone. And it was absolute pleasure on behalf of Dr. Reddy's, I would say. And Dr. Reddy's has always supported, and we promised, I think we will also bring in and support more such programs in future. I must thank all the faculties of all the 5 days, and also most importantly to you, sir, for all the guidance and developing the program. And once again, thanks and good night to all.
Good night. Bye-bye. Thanks.
Bye.
Thank you.
Good night. Good night. Thank you, sir.